All right, I welcome you all to this endocrinology USMLE step one organized by the Concept Academy. So I want you to be relaxed, like relax while you imbibe the important points with respect to endocrine system. So nothing difficult, is just what you already know, but just to bring them closer to you again. Okay. So we'll go through the embryology, anatomy, physiology, pathology, and pharmacology. Okay. So this is the endocrine embryology. We are going to be starting with thyroid development. Now, you cannot go into the exam and assume that thyroid is not important. That would be a very great error to commit. So, what is it about the thyroid development or thyroid embryology that you want to take into the exam? I just put it under these two canopy just to forget about the note. It may look a bit messy or notey, but I will try to explain myself to you. The thyroid actually develop in the first trimester. That's when the development of thyroid begin. All right. So I can't imagine how this is going to be tested, but just for you, you can think about anything. Maybe a drug is developed that affect the thyroid development. You might say at what trimester do you think probably the drug act or something like that. So you may just go now, say first trimester, second trimester, third trimester. So you can just go for first trimester. You can just pick something related to that. Now, thyroid develop from the fusion of two wonderful structures. Number one, median thyroid enlarge. Please note it very well. Median thyroid enlarge and two lateral thyroid enlarge. So just be imagining it. We have, I'm just going to represent it like this. I don't need to be accurate. This is the median. So this is the lateral. This is another lateral. You can look at it like that if you wish. So these are the lateral thyroid enlarge. This is the median thyroid enlarge. So they fuse. All right. Thyroid has two types of cells that you are all aware of. Probably you've forgotten. The first one is the follicular cell. Follicular cell. Follicular cell. The second one is the parafollicular cell. Can you see them? Very simple and straightforward. Where do you think these two cells are coming from? These two cells, they are coming from pharyngeal endoderm. Where? Follicular, parafollicular, pharyngeal. If you want to write your own pharyngeal like this, you can write it starting with letter F too, if you wish. Sorry. All right. So that is pharyngeal endoderm. This is very important because they may give a question where they will just say that maybe something happened and there is a problem with the follicle. They will mention it. It's not your own duty to be thinking the question for them. They will their own duty to write the story. They will now mention that our follicular cells, they are affected or something. It can now be like, what is the embryologic origin of the affected cell? So the answer is going to be pharyngeal endoderm. So these are the two types of cell we mentioned. Medial thyroid enlarge is the one that actually forms the follicular cells, while the lateral thyroid enlarge is the one that forms the parafollicular cell. When you say something is para, it's just like around or something that that is just like beside. You can look at it like that if you wish. All right. So that is for the lateral thyroid enlarge. They will ask it in the exam. You will see them mention something related to that. Another name for parafollicular cell is the C cell. C cells. Never forget this. C cell. Never and never forget this. C cell. C cell. All right. So that is for the parafollicular cell. Now, we have what we call thyroid difarticulum. And this is just the thyroid gland precursor, like the more or less like the first form of the thyroid gland, that is like where the thyroid is going to more or less like emanate from. You can look at it like that if you wish. So thyroid difarticulum. So initially at the middle of the floor of the pharynx, that's where you see it, near the base of the tongue. If you can imagine where the tongue is, that's where the thyroid difarticulum is. So where is around that, around which structure can you use as a landmark around that base of the tongue? That's foramen cecum. So from that area, that thyroid gland, that is now going to start descending into the neck. I mean, descending through the neck into the permanent anatomical site. Can you hear? Can you see that? It's supposed to descend. So as it's descending, it's going to be descending through what we call the thyroglossal duct. After the descent, you expect it to, this thyroglossal duct, the part through which it descends, to obliterate. So thyroglossal duct usually obliterate after the descent. Think about it. What of if the thyroglossal duct, the part through which it descends, what of if it doesn't obliterate? Anything can accumulate in it. A very good example is a fluid. If fluid accumulates in it, the patient is going to develop what you call the thyroglossal cyst. It's now going to develop a cyst. That's another important point that you need to note with respect to that descent part. They will ask it. And if at all someone presents with an anterior neck mass and you are not really that sure which mass is this, is it related to thyroglossal cyst or another entity entirely, you just ask the patient to protrude out the tongue, because this thyroglossal duct is associated or is linking the thyroid gland, is linking it to the tongue. So as the patient is protruding the tongue out, this cyst is also going to move. Once it moves with tongue protrusion, you will go for thyroglossal cyst as your answer. So that is the answer. All right, we've talked about the part, that channel, that dot, if it doesn't obliterate. What of if as the thyroid gland is descending, it doesn't get to the anatomical position, anatomical site it's supposed to get to? What of it becomes maybe it just hang around the upper part of that particular descent part? It can hang anyway, but it doesn't get to the anatomical side. So it becomes what we call ectopic thyroid gland. That ectopic thyroid gland can be around the tongue. You call that lingual thyroid. It shows that descent has failed. It doesn't take place the way it should. This is one of the questions you should expect in the exam. Lingual thyroid. So this lingual thyroid, when the patient now gets to the age that the thyroid hormone is needed in the patient's life, that thyroid gland will now become enlarged because it is in ectopic position. It's actually not going to be doing most of what it's supposed to be doing at ease. It's not going to be doing it at ease. So when there is a need for thyroid hormone to be produced, there will be significant enlargement. It's going to be stressing itself, become enlarged to cope. There are so many people in life, they're actually in their ectopic position. Where they are is not the anatomical position. That's why they labor. Like everything is very, very difficult for them. May God take us to our anatomical site. sorry to mention that. So that's one thing about this life. All right. So when there is a need for thyroid hormone to be produced, so it's now going to become a bit enlarged. So when it's enlarged, it's going to be causing a lot of obstruction. Then this physician or this surgeon will just come. The parent will just bring the child. I don't know this. My child is having this, blah blah blah, and the life will be like, okay, sorry, we need to do surgery. Maybe it's this, it's that. So they remove it. By the time they remove it out of the thinking that maybe it's not really that important or something like that, the patient is going to move into or become hypothyroidic, and the patient will start manifesting symptoms and signs of hypothyroidism, shikena. So now, how will they test this? They will just say that there is a patient that is coming to the physician, that has come to the physician, that present with maybe difficulty with swallowing. A particular mass is seen in the around the, in the pharynx, that was eventually removed by, or at the back of the tongue, that was eventually removed by the surgeon. After that, the patient starts gaining weight, start having cold intolerance, start having this, that, and all manner of stuff. When you see that, just know that the question is all about lingual thyroid shikena. That's the way the question will come. If you can remember that story, you will not miss it. And at the same time, remember median thyroid enlarge. They may give a particular, they can set a question here and just say that maybe there is a particular drug that was developed. The patient, they notice that the drug actually affects median thyroid enlarge, maybe one experimental drug. Which of the following cell is likely to be affected? So it shows that follicular cells will not really be formed the way they should. If they say the drug affects the lateral thyroid enlarge, then parafollicular cells will not really be formed. And that's how you will be looking at it. So I think that is the basic point I should try to leave with you. The distal portion of the thyroglossal duct, the one that is linked to the thyroid gland itself, that distal portion is actually going to form what we call the pyramidal lobe of the extrathyroid tissue. Just for you to know that portion, what is going, when it becomes obliterate, when that dot becomes obliterate, the distal portion, what is it going to form around the thyroid gland? So anatomically, I put something here. I call it a seat. So a seat. So this is just to give you an idea of how you will be thinking about the thyroid blood vessels and some important concepts around them. This E is external carotid artery, is the one that gives rise to superior thyroid artery. Then I is inferior thyroid artery, is coming from thyrocervical trunk. All right. So they may give you a question and just mention that the superior thyroid, there is the patient underwent thyroidectomy, and the surgeon actually tie superior thyroid artery. The vessel that is tied is actually a branch of which of the following vessel. So you just be like, okay, just use this exit, external carotid artery. Just write it down once or twice and you are going to get used to it. Then if it's inferior dimension, you will be thinking more towards thyrocervical trunk. And that's the basic thing. So now we have what we call neurovascular triad. Neurovascular triad with respect to thyroidectomy. So neuro, we have a nerve. Vascular, we have vessel there. So superior thyroid artery is the vessel and vein. They are the vessel. While external branch of the superior laryngeal nerve, they are actually the nerve in the neurovascular triad. When they are performing thyroidectomy, the surgeon needs to identify this triad, this neurovascular triad or bundle, to separate them so that the physician will be able to tie and ligate the vessel appropriately, at the same time not damaging the nerve. The reason is that if out of enthusiasm the surgeon goes and tie everything together, the patient is going to lose the structure that is supposed to be supplied by this external branch of this superior laryngeal nerve. Is not going to function again as such. Which structure is that? They will ask you in the exam. That structure is cricothyroid muscle. So external branch of the superior laryngeal nerve supply this cricothyroid muscle. So if that external branch is damaged, cricothyroid muscle will not be able to function very well, and the patient is going to lose the ability to actually, I think it deals with tenor voice or something like that. We lose that ability to give all those tenor voice. And so if the patient is a musician, the patient might not really be able to sing, the way maybe he or she used to sing very well. So just note this cricothyroid, because they will just say that the nerve damage in this patient supply which of the following muscle. The answer is cricothyroid. If you can know this simple concept about the thyroid, your mind will be at peace when you are reading the question. So that is for the thyroid. Let's come down to the pituitary gland. So, okay, before I leave the thyroid, there is also another mnemonic I put here that I must not forget to mention. We call it tap titles. You are going to apply tap titles in the exam. You need to write it down. This is one of the mnemonics in endo that you must learn how to apply very well. So this TA, you just pick them two. This is TA, PT, IT, US. The TA, they come from first pharyngeal pouch. PT come from second pharyngeal pouch, while IT come from third pharyngeal pouch. US come from fourth pharyngeal pouch. The TA, the stand for tympanic cavity auditory canal. PT from pharyngeal tonsil, tonsillar fossa. I, inferior parathyroid. T, thymus. U, optimobranchial body. S, superior parathyroid. Now, this is how they will test this area. If you look at this third and fourth, there is something that is quite common to them, and that is parathyroid. It shows that for the full parathyroid gland to be formed, the whole parathyroid glands you need the third and the fourth pharyngeal pouch. So to form them. So the third will form the inferior. With the fourth will form the superior. So they may just give a question and be like, they notice in this patient that the inferior parathyroid glands are not there. Think about it. Just think out loud. Inferior parathyroid glands are not there. So if inferior parathyroid glands are not there, they now say that which of the following are you also likely to see in this patient? The answer will be related to thymus. Likely thymus also is not there. All by just looking at the question, you realize that inferior is not there. Thymus also is not likely to be there. The extension, you now check through the option, you can't see anything related to thymus. Just check. They now say, okay, this patient is likely to have T cell dysfunction. Just be like, oh, T cell there will be problem with T cell. What if T cell is not there? They might just put something like there may be problem with maybe recurrent viral infection and the likes. So very easy and straightforward. Just look at the question and think. You just need to think. USMLE will bring something out of you, your ability to think as a doctor. A particular Indian man that wrote USMLE, had very good score, said something. USMLE should be recommended for all doctors across the world because USMLE does something to you. It gives you this ability to think deep as a doctor, whether you are going to end up practicing in United States or Canada or in your local country. There is something that is going to bring out. One, there is no case you are going to see that you will be afraid of. You may not know anything about the case, but you'll be able to think some stuff out, and any paper you read or any paper you read in any field, you will be able to make a reasonable conclusion out of the paper or make a reasonable launch a reasonable judgment on the paper, because you will start bringing concepts together when you are reading anything. So that is that. So you just need to think out loud. Any question, if you see a question and you miss that question, don't be afraid. You only miss that question. The subsequent question, you may not miss them. So but when you miss the first question, maybe you saw 40 questions in Word, and you now have 40%, you now start looking down on yourself. That's not how it is. You are only just starting. Do you get me? Later you will be getting 30 something, but that is when you don't give up. All right, so that is that about that. You can link that anyhow you like. So we come down to the pituitary gland. With respect to pituitary gland, we have anterior pituitary gland. We have posterior pituitary gland. Now, with respect to anterior pituitary, another name for it is adenohypophysis. First of all, why are you shouting adenohypophysis? It's important because if you don't remember that this is adenohypophysis and they are writing adenohypophysis in the question, you will not know that they are making reference to anterior pituitary gland. Posterior is the one they call neurohypophysis. So please, let's get that into our subconscious mind so that when we see it in question, we'll be able to know what they are trying to talk about. This anterior pituitary secretes all manner of hormones. So you are not just supposed to cram those hormones casually. You need to master them in a way, in a peculiar way. I put them together and call them flat peg. I just call them flat peg, but you can look at them and call them flat peg. All right, flat peg. These are the hormones. Now, this flat, F here is FSH, L is LH, A is ACTH, T is TSH. Why this P is prolactin, the G should be growth hormone. I just added this E to it, endorphin. So the thing about the flat pig, you can call it flat pig. I think you need to first of all remove this endorphin. I will show you where the endorphin is coming from. So just look at it as flat pig, just the way they wrote it here. Number one, where are the flats coming from? Where are the pig coming from? We have two sets of cells in the anterior pituitary. In fact, they are even actually up to like 3, but just look at them as 2 for the purpose of the exam. The first set, you call them acidophile. The second cell, you call them basophile. Okay, let us just say A cell, B cell. All right, I want you to name this flat pig and just put this maybe a flat or a peg or B flat or B peg. Just look at it. Which one do you think actually rhyme? I can easily say something like flat or flat B. You know, when we're in school, they name those flat A, flat B, maybe all those BQ, flat A, flat B, flat C, something like that. You can call this one flat B, and I can call this one a peg. It might be difficult for me to say B peg. A flat may go, but B peg will not really go. This one will help you to know that all these PG, basically, they actually come from acidophile, while the flat come from the basophile. So when they give you question and they say acidophiles are destroyed, they now ask you which of the following hormone will be reduced in this patient. Your answer will revolve around prolactin or growth hormone. If the question says the basophils are destroyed, your answer will revolve around any of these flats. So anything they can put on the acidophile, basophile, your own is just to look. So before your exam, I expect you to master this. Just for you to write it down. It's not cramming. Just write flat peg and put, okay, how can I name them so that the thing will make sense? Okay, flat B and a peg. So it will make sense like that. And that is another important point you want to note. Then, another important point that you need to put at the back of your mind is about this mother molecule. You call it pro-opio melanocortin. No matter how the name looks or sound in your mouth, it must never depart from your mouth when it comes to endocrine system. Pro-opio melanocortin. So this is the mother molecule that gives rise to these 3 hormones. What are they? We call them BAM. 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 So you can look at them like that if you will. So the B here is the beta endorphin. A is the ACTH. M is the MSH. So MSH is melanocyte stimulating hormone. Another name you can give it is melanocortin. So never forget that. So melanocyte stimulating hormone. So just look at it. Look at it like that. So melanocyte stimulating hormone. Then A is ACTH, while the B is the beta endorphin. So what this means is that anything that happens to ACTH, you will correlate it to these 2 other guys. So they will now give you a question. They give you a question where ACTH level is high. They will now say which other hormone is likely to be elevated in this patient. Your answer will be beta endorphin or MSH, shikina. So if anything happens to ACTH, whether increase or decrease, the same thing, you will correlate it to beta endorphin and MSH. MSH, if the level is high, is going to make the patient to have hyperpigmentation. So it shows that a patient that is having a tumor that is producing ACTH, that patient is going to have hyperpigmentation, because as the ACTH is being produced, MSH is also being produced, and that will give the patient hyperpigmentation. Relax. They will give you a question, blah blah blah, this one, you now see hyperpigmentation. Which of the following are you also likely to see in this patient? Just go through the table. Beta endorphin also high, ACTH high, MSH high. You just pick the option that, just by seeing hyperpigmentation in the question. It's just as easy as that, as ABC. So you must never forget this important point. All right, the last thing I will say about this hormone is about their subunit. This hormone, they have two basic subunits, and I will show you how this subunit will be tested. The first subunit is called alpha subunit. The second one is called the beta subunit. See, the alpha subunit is actually common. The alpha subunit of some hormones, they are common. Because they are common, they can actually stimulate one another's receptor. For example, a patient that has high level of HCG may start stimulating the what do we call it, a TSH receptor. Can you see? May start stimulating TSH receptor. So a patient that is having HCG being produced in its body, maybe because of one tumor or the other, so can actually start manifesting something like something that look like hyperthyroidism. So if they now ask you that this patient has a tumor producing high level of HCG, and you are seeing features of hyperthyroidism, which of the following is responsible for it? The answer is similar alpha subunit. Shikina. That's the answer. So you pick something like that and you won't be wrong. So they can also relate it to LH, FSH, basically. So you will be fine. Which tumor is most likely going to produce HCG? Very good example is choriocarcinoma. You can actually see choriocarcinoma in the what do we call it? You can see choriocarcinoma in a male. So you just see a male patient that the HCG level is high. If that male patient has high level of HCG, that HCG can be stimulating the TSH receptor, and the patient can start manifesting like someone that is having hyperthyroidism. You now check the thyroid hormone, you realize the thyroid hormone is low in that patient. So where is your hyperthyroidism coming from? You'll be thinking towards HCG. So it shows that their alpha subunit, they are actually similar. The same thing for the LH and FSH. So that's that about the alpha subunit. So what about the beta subunit? It's actually the one that gives those hormones their specificity. So the ability of the HCG to behave like HCG, that's quite peculiar to it. The TSH like TSH and the like. So beta subunit develop that. Determines that. So it's the one that determines the hormonal specificity. So these are just the few points you want to note about the hormone. What about the anterior pituitary gland itself? One, where is it coming from? The development, where is it coming from? It is derived from oral ectoderm. You must never forget, all these pituitary glands, they are derived from ectoderm. The anterior comes from oral ectoderm. If you check the option, you can't see anything about oral ectoderm, you go for Rantke pouch. So these are the specific things you master. So you are not just committing everything. You need to think about them and get used to them. So never forget this. This Rantke pouch or oral ectoderm, you will be tested on that. All right, let's come down to the posterior pituitary. You call that neurohypophysis. If I'm going to start, I can say that, okay, where do you think this posterior pituitary is also developed or derived from? This one comes from neuroectoderm. It's also ectoderm, but this one is neuro. So that's why you can call this one neurohypophysis anyways. So never forget, this is neuroectoderm. It's also ectoderm, but this is neuro. What are the two hormones you want to put at the back of your mind with respect to this posterior pituitary? Number one, vasopressin. Number 2, oxytocin. So vasopressin, another name for that is antidiuretic hormone. Oxytocin is the second hormone you need to put at the back of your mind. Now, we have this mnemonic called SAD pox. You can't forget SAD pox. Though this vasopressin or ADH and oxytocin, two of them, the cells or the cells that I'm going to talk about now, each of them secrete both of them. So what are these? We have you call them nuclei anyways. So you have what you call the supraoptic nuclei. You have the paraventricular nuclei. So supraoptic nuclei will secrete both of them. Never forget. Paraventricular nuclei will also secrete both of them. Never forget. However, supraoptic will produce more of ADH. Paraventricular nuclei will produce more of oxytocin. That is where the SAD pox is coming from. Doesn't mean that supraoptic is only producing ADH. No, don't mix it up. It doesn't mean paraventricular is only producing oxytocin. No. Each of them can produce both of them, but they produce them in different amounts. Never forget that. And these are the basic points you want to take into the exam with respect to the anatomy of the posterior pituitary. All right. We'll come down to the adrenal cortex and medulla. Everyone here knows about adrenal cortex. So, and medulla. We have about adrenal gland. We have the cortex. We have, this is actually the cortex, and this is the medulla. All right. The first question is, where is the adrenal cortex developed from? It actually developed from the mesoderm, while the medulla developed from neural crest cell. Wow. Mr. Neural crest cell is also coming in here. Yes, the same neural crest cell we looked at extensively in cardiovascular system. So neural crest cell for the medulla development, mesoderm for the cortex development. All right. So for the cortex, you have 3 layers, which when we were in school, they give them this beautiful mnemonic, GFR, glomerular filtration rate. You just arrange them like this from outside, inside. GFR. So sona glomerulosa is that G. Sona fasciculata is that F. Sona reticularis is that R. Festus, and thank you for mentioning what we knew already. We know, you know it. So why are we mentioning it? Because USMLE will give you this histology slide. They can put arrow on any area and I'll ask you, which zone is this? If you look at this sona glomerulosa, it is the one outside. So if you look at the sona reticularis, it is the one inside with respect to the cortex. Now, I want you to look at the surroundings of these two areas. Sona glomerulosa is aborted by fat layer here. So you have fat layer here. While the sona reticularis is aborted by this medulla. In the medulla is formed from neural crest cell. So medulla actually has pigmented cells. So when you check the slide, you are going to see. So they just put an arrow here so that you will understand the way it comes. You just see an arrow here. So you don't know whether, they put an arrow here, They put an arrow here. You don't know, am I dealing with sona glomerulosa? Because they won't draw the stuff out, just put one small slide and just put an arrow. You are not sure is this one towards the outside or towards the inside. You are not sure. So just look at this, look at it the way we are looking at it. So check the surroundings, the area that is like outside to that area. So if this is going to be the sona glomerulosa, the cells you will see here or the tissue you will see here is going to look a bit clearer. Whereas if the arrow is here, so if the arrow is here, the tissue or what you are going to be seeing around it here is going to look pigmented. You may see some dark structure in it, and that will make it medulla. So I already know that this area is going to be reticularis. So because I'm seeing something dark outside to it, so this is going to be reticular. This is going to be reticularis, while this will be medulla. If I'm seeing something clear outside it, this is going to be glomerulosa, and this is going to be the fat layer you see on top of it. Very easy and straightforward. You just need to write it down and note what is outside to each of them. Because when they give you the histology, you don't need to have read all the histology slide that you could ever see in question before you answered it. Just think it through, imagine it, change it, turn it upside down, reorient it. You will realize that you're thinking, imagine all manner of questions they can ask here. Sometimes your imaginations actually come true, most especially if you work with the Spirit of God. All right, so that is that about that. So GFR, note it, is going to help. Sona glomerulosa, what does it produce? Mineralocorticoid. Fasciculata, what does it produce? Glucocorticoid. Reticularis, what does it produce? Androgen. What of chromaffin cells? They are the one that produce the catecholamines. A very good example, epinephrine, not epinephrine. So when we get to congenital adrenal hyperplasia, we are going to see the simplicity of all this stuff, the way you are going to be looking at the question. You don't need to cram anything. Don't cram anything. Bang, you will be looking at it and everything will be flowing. All right, so let's look at the endocrine pancreas. What do you want to take into the exam with respect to endocrine pancreas? Note the arrangement of the cells. We have the pancreas, we have what we call the islet of Langerhans. So the islet is actually more or less like the collection of cells like alpha, beta, and delta cells. That's what make the islet of Langerhans. So what they can do, let us imagine some stuff here. What they can do is to give you this kind of diagram. Just say this is the islet. You just put arrow anywhere. They now say that this, the arrowed cell, the arrowed region, which cells predominate in that region. So look at it. So this is actually the islet. All right. The way these cells, the way they arrange themselves, peripherally, you see alpha. Centrally, you see beta. Then interspersed between them, you see something like gamma. All right. So if the arrow they are giving us is actually peripherally located, the probability that the cell, that if at all you pick any cell out there, the probability that is going to be alpha cell is going to be very high. If you check the arrow and it's more of central, you will go for beta. So if you check the arrow and it's more of in between, peripheral and the central, is likely to be the delta cell. Delta cell produce somatostatin, alpha produce glucagon, beta produce insulin. All right, so let us also imagine another pathology. Let us assume that something happened to this cell, to this islet. Maybe they just do a biopsy. They now realize that there is actually necrosis of the peripheral portion of all these islet cell. I'm just sorry to use that. Or there is inflammation that is more around the peripheral. Which of the following are you likely to see? Which of the following hormone is likely to be reduced in this patient? If the inflammation is more around the periphery, alpha cells will be gone. So if is gone, it shows that the patient is likely to be deficient of glucagon. The production of glucagon is likely going to drop. If the inflammation is centrally located and you notice that the central cells, they actually the central part of the islet is actually affected, and I say which of the following hormone is likely going to be deficient in this patient, you will go for something like insulin. So you can think about it so that when you read the question, anyhow the question comes, you won't say that I've never seen this before. You come down to what we call the endocrine physiology. What do you want to take into the exam with respect to endocrine physiology? I just want you to pick the point and not cram the table. This table is not meant to be crammed. If you are cramming it, you are just wasting your time. You will forget it. You don't need to cram it. All right. I'm going to first of all give you an idea of ADH briefly. The ADH is something all of us know. ADH actually, the function of it is to increase the water permeability of the distal convoluted tubule and also the collecting duct in the kidney, just to increase the water reabsorption. Apart from water reabsorption, there is another function that ADH also help with, and that is in the what do we call it, reabsorption of urea. But put that one aside. Note what ADH is meant for. ADH is supposed to reabsorb water. So if a lot of water are reabsorbed from the collecting duct, it shows that in a situation and where you have adequate production of ADH, the urine is expected to be concentrated. All right. Under which condition, what are they going to test in the exam that is going to be linked to ADH? Very good example is alcohol. They will just say this patient consume alcohol. Very simple concept question. Consume alcohol, and notice that the patient has been going to use the toilet quite frequently, has been having something like polyuria and the like. Which of the following hormone is likely reduced, or which of the following hormone is likely affected, or production of following hormone is likely affected in this patient? Just be thinking towards ADH. So all I want you to remember is ADH and alcohol. So people that consume a lot of alcohol, they end up urinating a lot. Now be like, after consuming, take this agbo. When you drink it, you see, you with all the sickness in your body, you will urinate everything out. It's a lie. So when they consume those alcohol, there will be a reduction in the ADH secretion, and most of those urine that is actually supposed to be concentrated, they won't be concentrated. So the patient will be losing most of those fluid in the name of urine, in the name of polyuria, and the patient can eventually become dehydrated. So that is just like for the ADH. We'll still look at it better again. The next hormone you will need to check is this corticotropin releasing hormone. When you hear the word corticotropin, you are talking about ACTH releasing hormone. You show that we need this hormone to release ACTH. Corticotropin releasing hormone. Corticotropin, another name for it is ACTH. So anytime I want to release ACTH, I told you that the ACTH is going to be released together with two other entourage, and that is what make BAM, beta endorphin, and this melanocyte stimulating hormone. Two of them will be released together. So if this patient is having high level of CRH, ACTH level is high, definitely MSH also will be what? High. Beta endorphin also will be high. So is there any drug that can reduce, or is there any drug that can actually affect the release of this corticotropin releasing hormone? And that drug is a patient that has been on glucocorticoid for a particular condition for a while. So reduction in this hormone is going to be reduced in a patient that has been on glucocorticoid for a while, maybe for one chronic inflammation or the other. So CRH level is going to reduce, and the next thing is that ACTH also will drop, MSH also will drop, beta endorphin also will drop. So that is about this. Just note this CRH and link it to ACTH, and anytime you are linking it to ACTH, you also link it to these other two guys. I need to relate this to MSH just for you to have an idea of how I've already mentioned it anyway. So MSH, what it's going to do is going to increase what we call melanogenesis by melanocyte. So it's going to actually stimulate the melanocyte to produce a lot of melanin. So therefore, there will be hyperpigmentation. So when you read the question and you are seeing hyperpigmentation in the exam, they now ask you that which of the following are you likely to see in this patient? You will go for MSH level will be high. ACTH level is also going to be high. Beta endorphin is also going to be high. Shikina. So where can you see this? You can see this in Cushing disease. We are going to look at it later. We'll look at all this stuff very well. Just get the gist around them and you will be fine. So another two hormone I'm going to be picking is dopamine and TRH. So one thing about dopamine is that dopamine is given a nickname, and that nickname is prolactin inhibiting factor. It shows that anytime the level of dopamine is high, prolactin level is going to drop. Prolactin level is going to drop. So dopamine reduces the release of prolactin. But we thought it's going to just focus on prolactin alone. It's also picking TSH with it. So the level of TSH is also going to drop. All right. So now, how are they going to test this area? Dopamine is actually can actually be produced from the from the brain, upper part of the, in fact, upper to where this pituitary is. A very good example is the ventral tegmentum. So dopamine is produced, can be released there, and is coming, and is now going to come and influence the pituitary gland. So if at all anything happens to the production of dopamine, these two guys will rise. Under which condition can dopamine production or flow from above down to the pituitary be affected? A very good example is a patient that had road traffic accident. So with that road traffic accident, maybe the person had head injury. With the head injury, they now say that they noticed the patient started having maybe hyperprolactinemia. Apart from that, they also notice the patient to be having maybe high level of TSH and all manner of stuff. So when you read that kind of question, just know that that head injury has affected the flow of dopamine from high up. Maybe there is a particular section that was affected that is now affecting the tract that normally maybe bring dopamine from high up to the pituitary gland. So you must never forget dopamine and prolactin together with TSH. It is a sin in endocrinology. All right, dopamine, prolactin, TSH. So when dopamine is high, prolactin is going to be low, TSH is going to be low. Think about this antipsychotic drug. Antipsychotic drug, another name for them is dopamine antagonist. They are actually dopamine antagonists. So when a patient is taking haloperidol or any of those antipsychotic, those drugs can also reduce, they can also affect the effect of dopamine. If the effect of dopamine is affected, the next thing you'll be seeing is prolactin will start what? Going up. TSH also will start going up. And that is going to explain the reason why you can see galacturia in a patient that is on dopamine antagonist or this antipsychotic drug. All right. Let us link this to TRH. Okay. So what is TRH? Thyrotropin releasing hormone. That is TRH for you. Thyrotropin. Thyrotropin means TSH, releasing hormone. So anytime the TRH is also acting, it's going to release both TSH and prolactin together. So any situation where you see TRH level being high is going to make TSH also to be high, prolactin also to be high. Think about it. A patient with primary and secondary hypothyroidism. I will explain all this primary, secondary to you. So primary means that the affected organ is the main organ itself, and that is the thyroid gland. Primarily, the thyroid gland is the one that is having the problem. So if the thyroid gland is having the problem, you call it primary. So thyroid gland is not releasing the thyroid hormone. The upper, this is the gland, this is the anterior pituitary, this is the hypothalamus. Hypothalamus will release what you call the releasing hormone, while the anterior pituitary will release stimulating hormone. All right. So if that is the case, for the primary, the gland is not releasing the main hormone. So that is primary. So the main hormone that is not being released cannot feed back. So we are not having negative feedback to reduce this other hormone. Because of reduced negative feedback, the level of TRH will rise. The level of TSH is also going to rise. So because of this high level of TRH, TSH also is rising, prolactin will also rise. That is the reason why a patient with hypothyroidism can also start having galacturia. All right. So another important concept is about the secondary hypothyroidism. All we see here is that TSH, anterior pituitary, is not releasing TSH. It's not releasing TSH. That negative feedback also, because TSH level has dropped, it cannot stimulate the gland to produce the hormone. So the hormonal level is also going to drop, and that is going, negative feedback is also going to reduce. TRH will now be very high. So in the course of TRH becoming very high, TRH will continue to want to stimulate the anterior pituitary to produce TSH and the prolactin. So because of this high level of TRH, the end result of it is prolactin also will end up rising. That high level of prolactin is going to give the patient galacturia. So never forget the TRH and dopamine on TSH and prolactin. You forget that at your own risk. So that's why I put the arrow together. Let us look at the next one. Growth hormone releasing hormone and somatostatin. For the growth hormone releasing hormone, what this one will do is to cause the release of growth hormone. All right, it's going to cause the release of growth hormone. Festus, this is becoming too much. What will they ask us on this? All right, relax. Let me tell you. For the growth hormone releasing hormone, it has a particular analog. You call that analog tesamorelin. You forget tesamorelin, you are joking. What do they use this drug? What do they use it to treat? HIV associated lipodystrophy. Forget that at your own risk. They will ask it. They will just say this patient has HIV lipodystrophy. You can describe it anyhow they like. So you must say a particular drug is actually given. This drug, how does it act or something like that? Anyhow they give it. So you go for something like the drug is actually acting by increasing the release of growth hormone or something like that. So that's actually growth hormone releasing hormone. All right, I will also show you more about growth hormone later when we get there. All right, so that's about growth hormone releasing hormone. What about somatostatin? Somatostatin will reduce the production of growth hormone, also TSH. So another name for somatostatin is growth hormone inhibitory hormone. It inhibits most of the other. So we are going to look at that one later too, the more. What about the gonadotrophin releasing hormone? What are the gonadotrophins in the body? FSH and LH. What USMLE basically wants you to know to bring it to the exam is how is this hormone released. So if the question talks about the gonadotrophin releasing hormone is released tonically. Tonically means that like there is a continuous release of gonadotrophin release. Just check the question. Is this question talking about continuous release or pulsatile release? So if the question mentions continuous or tonical release of gonadotrophin releasing hormone, so what it's going to do is going to suppress FSH and LH. But if the question says the gonadotrophin releasing hormone is released in pulsatile fashion, then it's going to help it's going to increase the release of FSH and LH. What USMLE need from you is just how is this released. So when you see them playing around FSH and LH, just trace that question. The only assignment you have is to trace the question and ask yourself, is it released in a pulsatile fashion or tonical fashion? If it's pulsatile, then definitely the answer will be increase FSH, increase LH. If the question says it's released in a tonical fashion, the answer is reduce FSH, reduce LH. That's what they need from you. Any other thing is too much. So let's look at the prolactin itself. If the prolactin is high, prolactin will suppress gonadotrophin releasing hormone. Never forget this. At the same time, it can stimulate lactogenesis. So you think about a situation where we have excessive production of prolactin, maybe pituitary prolactinoma. So with pituitary prolactinoma, there will be a high level of prolactin, then that will suppress gonadotrophin releasing hormone. So what do you think that will cause? LH, FSH level will drop. So if LH, FSH level is dropping, think about what the patient is going to have. The patient will have problem with ovulation, and that's actually what forms the basis for natural contraception. Why, when a patient that just delivered, where the prolactin level is high, it will be hard for such patient to actually get pregnant during like the first 6 months, most especially if the patient is practicing exclusive breastfeeding, where the patient is really breastfeeding very well. So prolactin level is going to be very high, because also from the continuous stimulation from the baby and the likes. So many factors also coming into play. So please don't let us forget this area and how they can test them. Okay, so that's that about this. Oxytocin is going to cause uterine contraction. They will ask it. Just simple uterine that's more than enough. Just check the question. Just a particular hormone is this that is causing uterine contraction. Which hormone is it? Just go and pick oxytocin. So that's how most of the time those questions can look like. It's when you are overthinking about them that you can't think straight. So please never forget, in summary, dopamine will be tested, and never forget to correlate it with prolactin and TSH. You can also remember TRH. Then somatostatin, growth hormone releasing hormone, to two of them, gonadotrophin releasing hormone and prolactin. Then never forget MSH. We come down to growth hormone itself. What do you want to take into the exam with respect to growth hormone? So look at this list. This is where your judgment is going to start from. So this is growth hormone releasing hormone. We need this growth hormone releasing hormone to release out growth hormone. So what are the factors that can make growth hormone releasing hormone to be released? A very good example is sleep. When a patient sleeps very well, they actually release a lot of growth hormone releasing hormone. Hypoglycemia. We also make the patient to release more of growth hormone releasing hormone, not hyperglycemia. It's actually opposite is actually the case in the society. For those that have listened to us before, I've explained this and I'll still explain it again. Hypoglycemia actually increases growth hormone releasing hormone, while hyperglycemia reduces it. Stress can make growth hormone releasing hormone to be released. Exercise can make this growth hormone releasing hormone to be released. Obesity, aging can make growth hormone releasing hormone not to be released. Now, I used to correlate this. Okay, when I'm done, I'll correlate it to a child that lives in a village where they hardly eat once. That they hardly eat maybe twice in a day, and a child that lives with parents in United States, probably maybe they eat like 5 or 6 times in a day and the like, so that you see the difference between them. So growth hormone releasing hormone is shy in the system. It will come and stimulate the anterior pituitary to release growth hormone. Now, this growth hormone, this is now where USMLE will hide. This growth hormone is released. How is it going to act? Growth hormone is only going to act basically directly on adipose tissue and indirectly through another hormone. You call it insulin-like growth factor 1. Another name, somatomedin C. Well, you may look at it. It's a mediator that helps to bring out the effect of growth hormone on the tissue. Somatomedin C. You can look at it like that if you wish. So this IGF-1, forget it at your own risk. They will test it. They don't have many things they test. Others are just story. Few things they will still test in different fashion. Once you understand the story behind it, you don't need to have solved all the U-word question before you pass. You don't need to. That's why I encourage people, when you are going for the exam, carry your first aid and revise like you don't like that is your Bible. Revise over and over and over and over again. On this page alone, when you have idea of all those stuff, when you are reading question, it's going to look like you know a lot and you don't really know more. You just know important points that you've revised over and over and over again. And when you get used to it, within a day, you can revise up to like 3 or 4 systems, because you are not looking for stuff. You are reminding yourself concepts. So this IGF-1, they will test it. It's one of the basic things you must never forget under growth hormone. So growth hormone effects is through IGF-1, indirect effect. Direct effect is actually on a particular tissue, and that tissue is adipocyte. Relax. Let me show you. For the IGF-1, what is it going to do? They give it that name, insulin-like growth factor 1. It's going to behave like insulin will behave. So if it's going to behave like insulin will behave, what will insulin do? Insulin builds. So you don't need to cram anything. You just come, the bone need to be built. If I am going to build bone, I asked you, I want to build bone. Do you think I will need amino acid? I'm very sure everyone will say yes. Do you think I will need protein synthesis? Say yes. Do you think I will need DNA, RNA synthesis? You say yes. Do you think I will need chondroitin sulfate? Say yes. Do you think I will need collagen? You say yes. You will just be listening to what I'm saying, and you'll be thinking, I will need this now. I will need it. So you don't need to cram anything here. There is nothing. It is none of your business. If I thought they ask them, they bring them out. Just look at them and be like, will this one be needed to build? Will this one be needed to build? If it's going to be needed to build something or a tissue, then that is correct. The same thing comes to muscle. I need to take up amino acid to build, to form protein. I need to build protein. Do you get it? To synthesize protein. So for the muscle, that is what insulin-like growth factor will do. I've built bone, I've built muscle, I'm building all manner of tissue. But there is one tissue that growth hormone will act directly on, and that is this adipose tissue. So what is it going to do to this adipose tissue? Growth hormone will come here and cause lipolysis. It's going to break the adipose tissue down, and there will be reduction in glucose uptake. Relax. Let me show you. So we have 2 patients here. One of them is living with the parents in United States. The other one is living in a village where they hardly live. The one that is living in United States is eating 7 times in a day. There is no evidence of hypoglycemia in his life. There is no stress in his life. In fact, he doesn't even want to exercise, to just sit down. So this one that is living in the city, in a developed country, eating 7 times in a day, is going to have growth hormone releasing, hormone production being reduced. So growth hormone level will be low. Now think about it. What do you think will happen to insulin-like growth factor? It will be low. Bone will not really be that strong. Muscle will not really be that there. Growth hormone itself is supposed to break down fat. Because the growth hormone level is low, these people will be accumulating fat, and you call them enjoyment. Or because this man is eating 7 times in a day. Alright, so you will see them, they will be big. They have a lot of fat. But their bone will be weak and thin. They don't really have muscle as such. All because they eat 7 to 8 times in a day. That's what happened. Now look at this guy that is in the village where they stress themselves a lot. They don't really eat, as they have sometimes they don't even have anything to eat. They run here and there because in the village you run here, we do all manner of stuff. So what happen here is that growth hormone level will be high. Growth hormone releasing hormone level will be high. Growth hormone will be released. Insulin-like growth factor level will be high. So because of this high level of growth hormone, they will end up breaking down most of their fats. So when you look at them, they look thin, but their muscle is very big, and they have their muscle big, their bone also very strong. So that is what they can put it in any way. You can look at the question anyhow. Once you understand that, you don't need any other thing again. Just remember, insulin-like growth factor direct effect is the one that is going to mediate indirect effect of growth hormone, while growth hormone will act directly on a particular tissue, and that tissue is this fat tissue. They will ask it. Never forget that. All right. So that's what they put here. Growth hormone, if the level is also very high, there can be increase in insulin resistance and the like. So what can make secretion to be high? You already know those things. You can just relate it to the village and the city. It will make sense to you. So if I told you there is excessive secretion of growth hormone, what will the patient have? The patient can have acromegaly if you are dealing with adults, gigantism if you are dealing with children. How do you want to treat? The drug they will test is somatostatin analog, and that is octreotide. Shikena. Another treatment is surgery. All right, so we leave the growth hormone level. There. Let's look at the antidiuretic hormone. Antidiuretic hormone. Where is it produced from? Hypothalamus. It can be produced from supraoptic nuclei, the paraventricular nuclei. So it's not that, maybe just remember sad pox. So be more from supraoptic nuclei. Never forget that. Then it's going to be released and be stored in the posterior pituitary. Okay, what are the function? The function is, one, it can regulate blood pressure. It can regulate blood pressure. It can also regulate serum osmolarity. Look at osmolarity. So look at it critically. This should be, you can call it osmolarity, you can call it osmolality anyway, but more of osmolality when you are dealing with, you are comparing weight to volume. Anyways, so it can regulate blood pressure. It can regulate osmolality, serum osmolality. What USMLE will ask you is by what receptor? So blood pressure, BLD. That's how most of us will have written blood pressure. Then osmolality. So osmolality, you can just write osmolality there. This blood, where I am writing this blood here, you can look at it as 1 anyways. So this will be carried out, regulation of BP will be carried out through V1 receptor. Now, question for us. Which molecule is going to help, or through which molecule will this function be carried out? A, CAMP. B, what do you think is going to increase CAMP, reduce CAMP, increase CGMP, reduce CGMP, increase IP3? Who want to make a guess?
IP3.
Reduce IP3, Abi?
Yeah.
It should be, if this is stimulating the receptor, you are stimulating the JQ, what do you think it should be? Is it increase or reduce?
Increase.
Increase. Shikena. And that's how very easy. We just did it now. Most of you are sleeping there. Just finish what you will. Finish. Let us go and sleep. You want to kill us. You will survive. It's not easy actually, but I hope you are getting it. I'm proud, maybe I was even talking to myself. Was I talking to myself?
No, sir.
No, sir.
No,
Alright.
sir. No, sir.
Okay.
Wait, I don't know.
But you didn't answer the question. You didn't answer the question. All right. So just get the receptor. They will just give you and just ask you that through which receptor they can. Okay. How do you think what of it too? How do you think this feed 2 will be, through which mechanism do you think is, through which molecule do you think the feed 2 will act? What do you think?
Cyclic AMP.
CMP.
CMP. Can you see the thing is
Okay.
very easy. You don't even need too much. You will just be, it will now look quite easy for you. All you need to do is to rehearse it and you are okay. All right. So that's that about the receptor here. Okay. The other part of this ADH here, we are going to look at it when we get to RENA. Don't give yourself too much headache. There is a third function for the ADH that I need to bring closer to you. I mentioned it briefly the other time, and that is reabsorption of urea. When we get to RENA, I will show you how important that is. So it's going to help in the reabsorption of urea. Never forget it. They didn't write it here, but I need to bring it out. Okay, reabsorption of urea. Never forget that. Okay, there is a condition we are going to be looking at very soon. You call it diabetes insipidus. So we have the central, we have the nephrogenic. So what is happening in diabetes insipidus? I'll show you why they call it diabetes insipidus anyway. So for the central one, ADH is not produced. This is all about ADH. Central one, we notice that ADH is not, that's why they call it central, because the thing is coming from central nervous system where ADH itself is not produced. What about the nephrogenic? ADH is in the system, but the kidney is not responding to the ADH. The kidney is not responding to the ADH. That is nephrogenic. How will I know which of them the patient is having? All you need to do is to give the patient desmopressin. When you give the patient desmopressin and you see improvement in the clinical condition of the patient, you say that ADH is not produced. You show that ADH is not in the system ab initio. But despite giving the patient desmopressin, you are not seeing anything, any significant change. It shows that this is not about the ADH, this is nephrogenic. And that's what you will be looking for in the exam. You are seeing something that I'll show you how everything will look like very soon. So let's look at prolactin again. Just the summary of what I've told you about prolactin. Nothing has changed. I mentioned 2 hormones. You must never forget. Anytime you want to think about prolactin, in fact, let me make them 3 today. TRH, dopamine, gonadotrophin, also release that you need to relate together with respect to prolactin. Okay, so TRH will stimulate prolactin, right, to be produced, while dopamine will inhibit prolactin to be produced. Shikena, that's what they need you to bring into the exam. So any question you are reading, when you see that prolactin level is high, you are like, this patient is having high level of prolactin. Maybe the dopamine level is low, that's number 1, or TRH is high. Under which condition will the TRH be high? You will not be like, am I dealing with primary hypothyroidism or secondary hypothyroidism? You just check through the option, just see hypothyroidism, just pick that as the answer. Prolactin level will be high. So you check through that, you are not seeing anything that looks like hypothyroidism. You now see something that looks like dopamine antagonist. You go for that. So that is about hyperprolactinemia. So never forget that the question in the exam will be related to hypothyroidism. Once you get the picture of that, when you are seeing all those prolactin, your thinking will be clear. You will know what you are thinking about. This is not that maybe you are doing guesswork. And when you read their explanation and they are talking about hypothyroidism in their explanation, you know where it's coming from, because this is prolactin. For the dopamine agonist, they can say that they give the patient dopamine agonist. So someone that is having galacturia, so they now say, how do you want to treat it? We notice that they will do hormonal profile for the patient. Prolactin is now high. Now say, how can I bring down this prolactin? You can give the patient dopamine agonist. When you give the patient dopamine agonist, it's more or less like you are stimulating more of dopamine in this. You are stimulating dopamine more in the system, dopamine receptor in the system, and that will bring down what? Prolactin. That's why you use dopamine agonist like bromocriptine, cabergoline. Sorry to laugh, but what actually makes me to laugh is that I look at bromocriptine like, when someone is like, prolactin, I learned that you are high. This drug is saying I will cripple you. Bromocriptine, Cabergoline is begging, like, please calm down. Cabergoline. So please, prolactin, you are high. Calm down. Maybe that may help some people in the examination. Dopamine antagonist, you already know antipsychotic, but there is another drug that probably you do not know, but you've been using, and that is metoclopramide. When people deliver and they are not lactating on time, we say that, oh yeah, place them on metoclopramide 10 milligram, maybe twice daily for like 3 days. Then the next thing you see is that they start lactating. So how is that metoclopramide helping? Sometimes they used to give them antipsychotic. They used to give them antipsychotic to induce that lactation for them. But they noticed that when they gave those recently delivered women this antipsychotic, some of them, they can even develop hypotension and even just fall by the maybe beside the bed when they are standing and all manner of stuff. So I think that's the reason. That's one of the reasons. I think I don't need to be correct. So I think that's one of the reasons why they don't usually use that as such again. So they just go for metoclopramide. You give it to them and they start lactating. So how they will now ask you in the exam, what is the mechanism? The answer is dopamine antagonist. Another thing is estrogen. So estrogen will be high. When we get to reproductive system, you will see all this stuff. Estrogen can also help, can actually increase, can also stimulate prolactin secretion, maybe in the name of OCP or pregnancy. All right, so that is what you need to know for the exam. Never forget this at all. TRH, dopamine with respect to prolactin. So a patient that is having renal failure, just as this patient has maybe CKD and the likes, and this patient just starts having maybe galactoria, they now say, what is the mechanism? The answer is there is reduction in the prolactin elimination. So it starts accumulating, and with that, the patient can start having galactoria. Please note this for the purpose of exam. We leave that, we come to thyroid hormone. What do you want to take into the exam? United States Medical Licensing Examination Step 1 with respect to thyroid hormone. Relax. Let us show you. I noticed that since we started, you've not been sipping something. I don't know why. But I know that as we were doing class, some of you were actually sipping something. You were like, whether you say we should sip something or not, we will sip something. You can't kill us. Is it because of just USMLE? You are like, sip something. Don't just sip something about it. Look at it simply, so that our journey is long. We can't at this level be afraid. So relax very well and be like, okay, this is how I'll be looking at this. What of thyroid hormone? There is no one here that does not know thyroid hormone. All of us, we have heard about it. Sometimes we even order it. So now let us throw more light into it. Number one that you want to understand, we have two. We have the T3, we have the T4. Anyways, T3, T4. So this is our T3, this is the T4. The first thing you want to notice, the enzyme that is important. There is a pathway that probably they put here for you to master. I'm very sorry to disappoint you that you don't need to cram anything. You don't need this diagram for anything in the exam. No one will ask you anything on it. If I thought they are going to ask you any question, you will be able to answer it easily because you don't even need the diagram. That's just for illustration purpose. So you need two enzymes to be at the back of your mind. So the first enzyme is thyroid peroxidase. The second enzyme is 5-deiodinase. These are the two enzymes that if you go into the exam, you forget them, they should crucify you head down. The thyroid peroxidase. So this is how they will test it. They will just mention, I say that you shouldn't bother yourself about most of this reaction. So they may now mention a particular reaction here that Festus says you should not bother about. They will just mention it and now say that which enzyme is important in this step. Don't even think the question, just check through the option and pick thyroid peroxidase. Because most of the reaction that you see that exists in the production of those thyroid hormone, majority of them are actually catalyzed by the thyroid peroxidase. So if you can just look at that, like look at the question like that, you will leave the examination or happier than someone that is trying to remember a lot. Whether you get it right or wrong, just look at it like that and move on. So that is thyroid. Once the just thyroid peroxidase, right? Thyroid peroxidase. They are like, what's the thyroid peroxidase saying? They are like, just pick that. You now go and confirm. It's correct. It's correct. So thyroid peroxidase. The second enzyme that you must never forget is 5' deiodinase. How are you going to be applying this? God is so wonderful. God looked at us and it's like, this thyroid hormone that the body is going to be producing, let me capture majority of them in the form of this T4. Majority of the thyroid hormone that will be produced, they are T4. When the body needs the thyroid hormone, some of this T4 will be converted to T3 peripherally. That is where that conversion occurs. All right. So 5' deiodinase is the enzyme that catalyzes the conversion of T4 to T3. So where are you going to see it? So peripherally. That's where you see it. So never forget these two enzymes. That's how this can be tested. So is there any drug that can inhibit this 5' deiodinase? Yes, there are drugs. Number 1, beta blocker, propylthiouracil, glucocorticoid. Out of these 3 drugs, the one I want you to note with passion is this glucocorticoid. It doesn't mean the others are not important. They are also very, very, very important. But glucocorticoid, I want you to note it with passion. The reason is that glucocorticoid normally, when we want to manage a patient with thyroid problem, is not one of the common drugs that you look at. It's not one of. So when you see the glucocorticoid being introduced, it's actually under a peculiar situation which we are going to see later. What does that one mean? You are reading question, you now start listing all manner of drugs, you now see glucocorticoid, and I have seen it before. You now want to rush to it. Be very careful. Check through that question again. Hope this question actually meets the kind of question or condition that most of the time we use glucocorticoid for with respect to this thyroid pathology. So just note it: glucocorticoid, beta blocker, PTU. PTU we say, we didn't say metimers. Please just note that PTU. All right, so that's about the 5' deiodinase. The next one is what we call euthyroid sick syndrome. What is this, for crying out loud? What is euthyroid? What is sick? You are even talking about syndrome. The name is looking somehow. Relax, let us show you. Euthyroid is more or less like when you look at the hormone of that patient, the thyroid hormone, there's really nothing wrong with it. When you look at the patient is likely to be sick. Then you will now see some some constellation of manifestation that this can actually present with. So this is how T4 is being converted to T3. This is what God did. God actually did it like this. T4 can be converted to T3. It will also be converted to what you call reverse T3. That's the conversion. All right. So, God is wonderful. If you do not appreciate him, take your time when you study medicine. You are looking at all this stuff. Appreciate him. He did a perfect job. So we don't now know, but he did a perfect job. T4 be converted to T3, reverse, then also to reverse T3. So what happens is that when the patient is sick, you can't eat, you are not going anywhere, But these T3 normally show they're actually catabolic hormones. All these thyroid hormones, they are catabolic hormones. They help with metabolism in a way. So if we allow, go look at it as like, if we allow T4 to continue to produce more of T3, there will be a lot of catabolism going on in this patient that is lying in bed in ICU. All right. So anytime this patient is sick, T4, don't be forming T3. Start forming reverse T3. Reverse T3 is metabolically inactive. Reverse T3 is metabolically inactive. So when you look at that patient, you take the blood of that patient, now check it, you will realize that the T3 level is low, but the others, they are normal. TSH will be normal. Not T3, reverse T3 is not part of what I'm talking about the others. So TSH will be normal. T4 will be normal. You will now see T3 will be low. We now give it a name. We call it low T3 syndrome. So when they give you question and you look at the hormone they give you, once you see reverse T3 in it, you now realize that it's in fact, which one is even elevated. You look at the question and you now see that this patient is sick. This patient is admitted into ICU. They now ask you, what is the thyroid hormone profile likely to look like, or something like that. Just know that T4 will be normal. TSH will be normal. However, T3 will be low. That is what will happen initially. If that continues, then you start seeing that T4 level will start dropping. All right, so T4 level also will start dropping. That's later anyway. All right, so look at this. I put it here early. You just see T3 level is low. T4 will be normal. TSH will be normal. But if that continues for a while, T3 level, TSH will now start dropping. T4 also will start dropping. So any of them they give, once you are seeing low T3, never forget that you are likely dealing with euthyroid sick syndrome. Another name, low T3 syndrome. So they will test that in the exam. Just see, it's one of the commonest things they test in the exam. So there is nothing logical about it. It's just qualitative reasoning. Just look at it and be like, okay, this patient is sick. God is so wonderful. And this, blah, 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 blah. Okay, this is what's going on. And that's all. All right. Another important point you want to note here is the significance. Of thyroglobulin. Thyroglobulin is not one of the regular hormones. You will see them mentioned in the question. The only thing that will make me to come to this diagram is Mr. Thyroglobulin. Let me show you. Thyroglobulin, this is it. You call it TG. All right. You are not supposed to see thyroglobulin in the blood. Relax, sip something. Sip something so that you will get the gist. You are reading this beautiful question. Your eyes just eat thyroglobulin in the question. That should be where your analysis will start from. You should start from there. Thyroglobulin in the blood, okay? How? Just be shouting, how did you get it? How did you get it? Relax, just quickly trace, because that is what you will need to answer that question. Thyroglobulin is not supposed to be in the blood. If we by mistake see it in the blood, it's either this, most of the time, this cell they are lysing. It's like they are breaking down. They are breaking down. That is what it means. So when you read the question and you now see thyroglobulin in the blood is high in the blood, until proven otherwise, you will say the patient has thyroiditis. The type of thyroiditis that the patient now has, you do not know. I will get to thyroiditis and I will show you. The only thing you just see there is that thyroglobulin is here. T3 is T3 level, T4, all those hormones, they are high. You are like hyperthyroidism, hyperthyroidism, hyperthyroidism. Just that thyroglobulin to be there. All the causes of hyperthyroidism you drop them. It's grave disease. This is not grave disease. Toxic, no, it's not. Multinodular, no, it's not. It's likely going to be thyroiditis. So thyroglobulin will help you, will bring you closer in the exam to thyroiditis. If after this you still go and read question and you are just looking at it anyhow, something is wrong. All right, the last but not the least point I'm going to make here is Wolff-Chaikoff effect. Festus, why did you put off in black? Maybe you wrote all the others in red. Yes, because that is the word you need. What happened? God, you are too wonderful. God puts a checkmate mechanism in the thyroid. Because thyroid, the way the thyroid is structured, is that anytime thyroid is exposed to the ingredients to produce thyroid hormone, it starts producing thyroid hormone. Whether the body needs it or not, it will just be pushing them out. A very good example is a patient that is placed on amiodarone. Iodine is there, the patient may start producing a lot. So the mechanism that God put there to checkmate it is what we call Wolff-Chaikoff effect. So what is Wolff-Chaikoff effect? Anytime the patient is exposed to any this iodine containing molecule, drug, contrast, anything, the thyroid gland will automatically switch off the mechanism involved in thyroid hormone production. So what you will see around that time is actually reduction in the T3 and T4 production, shikena. That is Wolff-Chaikoff effect. It's more or less like, there is a surge, off that, off it. Wolff-Chaikoff, off it, switch it off. So check the options and this is what is going to happen. And that's that. And that offing it is actually temporary. So after a while, when the kidney has removed that molecule, the thyroid gland will switch itself on back. God is wonderful. So that's that. Let's look at the thyroid function. What do you want to take into the exam with respect to the thyroid function? All right. First aid actually wrote 7 B's of thyroid of the function of the thyroid hormone. I wanted to say 7 B's, most especially the T3, the active one. The brain maturation, bone growth, beta adrenergic effect, basal metabolic rate, blood sugar, breakdown lipid, blah blah blah, and the likes. Which one are they likely going to ask me question on? The one they are most likely going to ask to test in the exam, they are this one I put in the box. Most likely, I say. It doesn't mean they can ask the other before you start looking for my neck or head. So the first one is beta adrenergic effect. How come a patient with hyperthyroidism have tachycardia? Because the thyroid hormone can actually stimulate the beta-1 receptor on the heart. So if it's stimulating it, with just the receptor they will test. If it's stimulating it, there will be increase in contractility, increase in heart rate, increase in stroke volume, increase in cardiac output. So that is what the patient. So you can actually block this by giving the patient beta blocker. Now, the beta blocker you want to give to the patient, is it now going to be cardioselective or non-cardioselective? You go for non-cardioselective. The reason is this: apart from until proven otherwise, let me put it that way, until proven otherwise. So the reason is that beta blocker, apart from when you give the patient that patient beta blocker, apart from blocking this beta-1 receptor activation on the heart, it's also going to limit or reduce or inhibit the 5' deiodinase that is converting the T4 to T3. So that is the reason why you just need to look at the question very well. Which one, and if at all there is any contraindication to the use of what do you call it? Maybe the non-cardio selective and the likes, you may just go for the any one that they put there. I think there are still some other drugs that you can actually still use with respect to this, but we leave those ones for now. That's number one. The next one is basal metabolic rate. They will ask you, how come the decision is that I have heat intolerance, I have this, I have that. So why? It's actually from increase in the activation and the level or the number of this sodium potassium ATPase. They will test this same sodium potassium ATPase, they will test it. So that is going to increase oxygen consumption, a lot of energy will be generated, and that will actually lead to a lot of heat being produced. So never forget this sodium potassium ATPase. So what about the sugar? Blood sugar level also can rise from increasing glycogenolysis. You take glycogen, you are breaking it down, or you are also producing more new glucose. So note these three very, very well as you are going into the exam, so that when you see the function, they are asking this, you won't be shouting which receptor are they testing, which channel are they talking about. 99% likely to be tested in the exam. How do we regulate this bastard? The thyroid hormone. So you remember our follicular cell. So you remember the follicular cell, you remember the parafollicular cell that I told you about, where the follicular cells are actually coming from. So basically from the media enlarge. Never forget that thyroid enlarge. Never forget that. Okay, so there are two ways that you must be registered at the back of your mind how those follicular cells can be stimulated in life. Two. If at all there are others, please note them. You can put them somewhere. Maybe when you get there, you can start bringing them out. The first way is through TSH. This is the one God put in the system, in our body. Thyroid stimulating hormone. So TSH can come and stimulate the follicular cell. Another way is through a pathology, and that is thyroid stimulating immunoglobulin. Where are we going to see this thyroid stimulating immunoglobulin? In grave disease. So a patient with grave disease that is producing a lot of thyroid hormone, how, by which mechanism do you think those thyroid hormone are produced? Through TSI. A, they will put A, TSH. B, TSI. Just go for TSI. Thyroid stimulating immunoglobulin. Shikena. So never forget this, rehearse it, say it to yourself, analyze it in the table, in your book, and you will be fine. There is another concept. Before I talk about that concept, you need to understand this equation. In endocrinology, when you mention the word total most of the time is equal to the bound form and the free form. So if they give us the bound form, the free form you do not know, and they tell you that the total is low, probably maybe the free form is low or anyhow, but never forget that anytime total changes, any of these could have resulted or caused the change in the total. All right, total is equal to the bound. What are those hormones binding to? They bind to some of the hormones, majority of them produced by the liver. So globulin, albumin, and all manner of stuffs. So now there is a particular binding hormone that this thyroid hormone can easily bind to, that you must never forget, that USMLE will test, and that is tyrosine binding globulin. How are they going to test it? There is just a particular concept, two concepts that they are going to use to test it in the exam. Number one is through estrogen. Now let us establish it as a rule, and that rule is that any binding globulin they give us in the exam any binding globulin they give us in the exam, estrogen will increase it. Let us take it as a rule. Any binding globulin we see in the exam, estrogen will increase it. So if this patient is pregnant, estrogen level will be high. Tyrosine binding globulin also will be high. If this patient is consuming oral contraceptive pill, estrogen that contains estrogen level will be high. Tyrosine binding globulin also will be high. So what will this tyrosine binding globulin do? It will come and bind to majority of the free. Binding to majority of the free, they will now become bound. Then that means the free will reduce. Actually, no. The free will reduce transiently. Body will respond immediately and raise the level of the free back to normal. Think about it. It is a table question. This patient is using OCP. Which of the following are you likely going to see in the patient? They now write free, bound, total. The free, you go for normal. The bound, you go for increase. The total, you go for increase. In as much any of them has increased, the other one, the total will definitely increase. The reason why you won't say free should reduce is because if the bound is increased and free is reduced, the total should be constant. But it's a lie. When the bound increases, the free reduces, transiently, immediately the body will respond and raise the free back to normal. So they will hazard, it's a table question. Just quickly, just look at it and be like, okay, that's what is going on there. All right, that is one way with respect to estrogen. Forget that at your own risk. Is there another way? This tyrosine binding globulin can be eliminated from the body or is not really being produced. All right, how? A patient that has been using steroid use can actually reduce this tyrosine binding globulin. A patient that is losing protein, as in nephrotic syndrome, is going to reduce the level of this tyrosine. Another condition you can think about a patient with liver disease. So they can actually also have reduction in this tyrosine binding globulin. So if at all there is a reduction in this tyrosine binding globulin, definitely you will be thinking more towards maybe the total is likely going to drop. Do you get me? So just think about it straight. No too much serene. Thank you so much, Festus, for your atotonu for this morning. Although we are sleeping here, but some of them are still entering into our head. We know you are sleeping. That's how people used to sleep anytime we are talking. But I know that you go back and go and sleep well. For some of you, in fact, we are done encouraging people. We don't have any encouragement in our mouths. The last point here that you need to note is about the T3 and T4. The fact that T3 and T4 are the only lipophilic hormone with charged amino acids. So they require a specific transporter to diffuse into the cell through facility. They just need to know that they need to go into the cell to go and execute their function. We are done with the physiology of the thyroid hormone. So if I thought you are now reading questions, look at those questions in this fashion, you will be very, very happy. Let's look at the parathyroid hormone. Parathyroid hormone, they are produced by the chief cell of parathyroid gland. All right, what will this hormone do? They have a way of also executing their function. One, they have some direct effect. They also have some indirect effect via the vitamin D. All right, so what do they do? When the parathyroid hormone is released, they will go to the kidney and try to activate vitamin D by activating what we call the 1-alpha hydroxylase. So when 1-alpha hydroxylase is activated, that is going to that's going to now help in the production of active form of vitamin D. What will the vitamin D do? The vitamin D will go to the intestine, reabsorb calcium and phosphate. It doesn't have any predilection for any of them, or for any of them. It's just going to reabsorb two of them. It will go to the bone, bring in calcium, bring in phosphate. So it's now going to load the blood with calcium and phosphate. Parathyroid will now look at vitamin D and say, I am highly disappointed in you. Like, I only asked you to help me with calcium. The calcium in the blood of this patient is low. Help me reabsorb. And you are bringing in calcium and phosphate. And vitamin D will say, no, I can't do that. I can only bring in two of them. All right. Well, you've done well. I will throw out the phosphate. I don't need phosphate. So the parathyroid hormone will come and go to the proximal convoluted tubule of the kidney, throw out phosphate. Festus, this one that you are shouting, throw out phosphate. They will ask you which part of the kidney, which part of the nephron. So it is proximal. So letter P for the phosphate. Very easy and straightforward. Letter P. So at which point in the nephron do you think the parathyroid hormone is throwing out the phosphate? So you will be thinking more towards something like, and how is it doing that? It's just reducing the reabsorption of phosphate. So what about the calcium? Because the blood naturally is flowing to the kidney. Calcium will be filtered, phosphate will be filtered. So what the parathyroid hormone will do is that calcium, you don't go, I need you. Is going to reabsorb calcium. Where? At the distal convoluted tubule. So if you look at it, letter D is closer to letter C. So if they ask you at which part of the nephron is the calcium reabsorbed, you go for distal. At which part of the nephron is phosphate reabsorption reduced, you go for proximal convoluted tubule. Which hormone? Parathyroid hormone. All right, so that's another important point, and I talked about the activation of vitamin D. Where is this enzyme located? Proximal convoluted tubule. They will ask it. All right. Any other point? There is a point they can also put in question when they are talking about parathyroid hormone activity. So, and the activity is actually going to be the CAMP2. So when you check the urine, anyways, for the CAMP level is going to be high. They love to put this in table question. They'll say that, okay, this patient has high level of parathyroid hormone, blah, 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 and the like. When you check the urine CAMP is going to be high. Because the others, you can easily, if you are throwing out phosphate in the urine will be high. If you are throwing out phosphate in the serum will be low. If you are reabsorbing calcium will be high in the serum. All right, so that's that. Is there any other thing again you need to know? It's about this rank L, rank ligand and rank. Rank ligand, and the full name of it is receptor activator of nuclear factor kappa B. You don't need to know the full name. You just need to remember rank ligand and rank. I've explained this before for those that have joined one or two of our seminar. Now, in the exam, there are two cells they will be making reference to in the question. They will. It's not maybe. We have the osteoblast. We have, let's call this B. We have the osteoclast. These are the two. They will be making reference to them either in option or in question. All right. I used to say something. I blasted him. If I am the one blasting you, it means you keep quiet while I talk. So it shows that osteoblast is the one talking. How do you know he's talking? He's expressing a particular, He's talking in a particular language. I call this rank language. The name is actually rank ligand. So if they ask you which cell will secrete rank ligand, which one is blasting in that language, you say blast. The answer is going to be osteoblast. So osteoblast is going to be producing out what? The rank ligand. So what about the osteoclast? Osteoclast is now the one that will be expressing the what do we call it? The rank. Osteoclast is expressing the rank that this rank ligand will come and bind to. I am talking, the language I'm speaking is binding to you. So I am more or less like osteoblast. You are more or less like osteoclast. That's number one. So when they are mixing up this osteoclast, you already know which one you need to relate rank ligand to, which one you need to relate rank, which is more of receptor, rank to. The next important point is between these two cells, which one expresses receptor for parathyroid hormone. They will put it in the exam. They will put it in the exam. The effect of parathyroid hormone you see on bone is actually mediated through osteoblast. Osteoblast is just the main cell that expresses receptor for parathyroid hormone. So parathyroid hormone receptor, you see it on the osteoblast. So if parathyroid hormone now come and bind to this receptor, osteoblast will be activated. Now start talking. Especially the right ligand and that ligand will come and now bind to the osteoclast. What do you think osteoclast will do? Osteoclast will now come and start breaking down bone. Do you get me? So now there are two ways to it. If the release is actually more of intermittent, pulsatile, so parathyroid hormone is going to end up stimulating bone formation. If it's continuous, it's going to end up stimulating bone resorption. Never forget that. And that bone resorption, they will ask you which cell is mediating that? Osteoclast. If it's going to be bone formation, which cell will be mediating that? Osteoblast. This is a fact everyone knows. So that is about this area. The last thing here is that God looked at it and it's like, we need to put a system in osteoblast that is more or less going to be like a checkmate. Let us look at it like that, like a checkmate for osteoblast, so that osteoblast will not continue stimulating the osteoclast like that. The checkmate that God put there is osteoprotegerine. So let me put osteoprotegerine like this. They are like this. Inside the osteoblast, they are just like this. So osteoprotegerine, if the body does not want osteoclast to be activated, osteoprotegerine will also be released. They will now come and now bind to all those rank ligand. Can you see them? They will just bind and like cup them. So you imagine I'm talking here and I'm muted and you don't hear me. And you say, you don't hear anything, but I'm still talking. So osteoblasts can still be expressing the rank, but most of them are just cupped by the osteoprotegerine. So they can talk about the ratio of osteoprotegerine to rank ligand. So if you have more osteoprotegerine to rank ligand, you'll see that all of them will be cupped. If you have more rank ligand to osteoprotegerine, some of them will still go and bind to the osteoclast. It's just a matter of ratio that you can mathematically analyze. The last but not the least here is about parathyroid related peptide, PTHRP. What happened here is that we look at the patient. We are seeing features of elevated parathyroid hormone. You just see calcium high, this one high, that one high. You're like, what happened? Parathyroid hormone is high. Just trace that question. You check the parathyroid hormone, they say it's normal. It's a lie. It's a lie. Calcium is high now. You check. Again, what about the vitamin D? Normal. What is going on? They now tell you that patient has been having weight loss. The patient has been having symptoms and signs that you can peg on a carcinoma. Once you see that, the molecule that is mediating that high level of calcium is parathyroid hormone related peptide, shikina. Alright, so never forget this. They can also mention that the level is high. They can give you the value. So most of the time, you just see this squamous cell carcinoma of the lung, renal cell carcinoma. Let us mute our mic, please. Alright, so that is about the parathyroid hormone. Now you come down to this area, you call it what do we call it? The common causes of hypomagnesemia in question. You now chop apple, you are like, "Oh, this is one of the things I want to forget." It's a lie. You forget, you are not going, they won't forgive you. If you forget, they won't forgive. Even if you forgive yourself, they won't forgive you. You'll come out and you're like, well, I take it like that. They won't take it like that. You can't forget hypomagnesemia, the cause. Because in United States, people take alcohol like anything. Like, hey, people take alcohol like anything. So you want to get used to one of these things. So they will just give the question and they will give the electrolyte. You just see that magnesium level is low. They will now ask you that, what do you think is the likely cause here? The most tested concept is alcohol use disorder. So they can also give a patient with alcohol use disorder and ask which of the following are you likely to see in this patient. So the answer will be hypomagnesemia. Magnesium level low. Other causes, they are diarrhea, aminoglycoside, and diuretic. So because as those electrolytes are being lost, magnesium is lost with them. So if in the exam, please watch out for alcohol use disorder so that you get used to it very well. Say it out, mention it, and play around it. In fact, if you see your friend that is taking alcohol, just tell that you are reducing your magnesium, be drinking it. Just say it jokingly so that you will not forget in the exam. All right, so let's leave that. Let's come down to calcium homeostasis. What do you want to take into the exam with respect to calcium homeostasis? So we have what we call albumin. This is albumin. We now have what we call hydrogen ion. We also have calcium that want to bind to albumin. So two of them are going to compete to bind to albumin. Look at it like that. All right, so think about it. In a situation where hydrogen ion is high, please pay attention to this very well. A situation where hydrogen ion is high, like in acidosis, because hydrogen ion is now high, most of the binding will be to hydrogen ion. So what do you think is going to happen to calcium? Calcium will exist. I mentioned those binding molecule, protein. The other, I mentioned one of them is albumin, right? So if hydrogen ion is high in the body, most of the binding will be to hydrogen ion. What of calcium? Calcium will now exist as free. So if calcium is existing as free, there will be this spurious manifestation as hypercalcemia. This patient has hypercalcemia. What do you think? How do you think parathyroid hormone will respond to that? Parathyroid hormone that is normally released to raise the level of calcium is now going to see hypercalcemia and is going to bring down its own production. So there will be reduction in parathyroid hormone secretion, Shikina, just by seeing acidosis. So this might just be a question where they will list the electrolyte and the bicarbonate level is just going to be low. Or they just talk about lactic acidosis, just any form of acidosis, they just mention it there. You just see that there is acidosis in this question. They now say, which of the following are you likely to see? And you just start mentioning electrolyte. Calcium high, this one low, this one that, and the like. So you know that definitely the free calcium will be high because they are not bound. The high level of free calcium will make the parathyroid hormone secretion to drop. Shikena. Okay, let us make this patient to have alkalosis. So if the hydrogen ion level is low, most of the calcium will be bound. So what do you think will happen to the free calcium? It will drop. The dropping of the free calcium is going to exist as hypocalcemia, and the next thing you will see is symptoms and signs of hypocalcemia. I used to illustrate hypocalcemia in a way, it might not be too correct, but it will give you an understanding of what is actually going on. So this is actually the sodium channel. All right, then you have calcium, they are more of bouncer at the entry of the sodium channel, just like the party that you used to go to. So bouncers are there. If sodium want to rush in, this bouncer will say that, hey, sodium, you can only enter one by one. You shouldn't rush in. So these two bouncers, the calcium, they now go to urinate. People that want to enter into the party, what do you think they will do? They will rush in. You shall remember what happened during Davido's wedding. So probably maybe this is one of the things that happened. No wonder there is some carpopedal spasm with respect to the wedding. So because when they rush in like that, some will rush in and the patient will start having spasm. So can have cramps, pain, paresthesia, carpopedal spasm. So in case they illustrate this in question, you have an idea of what is going on. So if there is hypocalcemia now manifesting as hypocalcemia, because majority of them are now binding, so the net result that you see with respect to parathyroid hormone is that it will respond to that and the level will rise. That's all they want you to note with respect to this area. Acidosis, alkalosis question with respect to calcium homeostasis. What of calcitonin? Calcitonin is produced by this cell. You call them parafollicular cell. They are the C cell of the thyroid. And you remember they are coming from lateral thyroid enlarge. That's where they come from. So they will produce calcitonin, and the calcitonin normally opposes the action of parathyroid. You don't need to know much, just pick them like that and you will be fine. Let's come down to insulin. What do you want to take into the exam with respect to insulin? All right, number one, how is insulin produced? They won't forgive you if you forget that. Insulin is actually produced from this mother molecule. You call it pre-proinsulin. When we get into biochemistry, we will unravel the mystery behind this. Behind all this pre-pro molecule. So pre-proinsulin, so which is synthesized in the rough endoplasmic reticulum. For all you care, this might just be the organelle that they will test. That might just be the organelle that they will just test there. Rough endoplasmic reticulum of pancreatic beta cell. So from the pre-pro, it will be cleaved, and the cleavage of pre away will produce proinsulin. Then the cleavage of pro away will now produce insulin together with a particular molecule. That molecule you call it C-peptide. So in the exam, the USMLE that you want to write, they will give you the value for the insulin and give you the value for the C-peptide. The value, they are actually produced equally. That is how it should be. If I thought there is a change in that balancing, you start suspecting something going on in a way. So please watch out and you'll see the way we'll go about it. So let us assume that you check the question. The C-peptide is very high, more than the normal range. Insulin is also very high. They now ask you, what do you think is causing that? You will check through. Either you are dealing with a tumor producing this insulin, like insulinoma, or you are dealing with a drug where that is actually increasing insulin secretion. You talk about insulin secretagogue. So they might talk about a boyfriend and a girlfriend that they have issue between themselves, and the girlfriend is just like trying to get the attention of the boy and just carry this and just take some drugs, and they now check the level of the patient blood. The patient shall lapse into hypoglycemia. They carry the patient to the hospital. They check the blood of the patient and they see that insulin is high. C-peptide is also high. They now say, what do you think is going on? Do you get it? So you'll be thinking towards injection of what? Insulin secretagogue. They will also put insulinoma there. But if you look at it, you can see a premise. There is a little fight. The patient suddenly laughs. Is it tumor that will now develop overnight like that? It's a lie. So you will go for insulin secretagogue. So likely the patient ingests that, and it can also be a factitious hypoglycemia in a way. So we'll be looking at that later. Another one is when they give you where the insulin level is high, but C-peptide is normal or low. When you see that, it shows that this patient actually take insulin exogenously. So maybe the patient is a diabetic patient that is on insulin, now give himself or herself a lot of dose. So all you are doing in the exam is to check, are they equal? Which one is high? So if insulin is higher than C-peptide, you'll be thinking more towards insulin coming from outside. If both of them are very high, you'll be thinking more production from inside, which can be from a tumor or from a drug that is stimulating the production. And that is what they want you to note in there for the exam. You come down to the function of insulin. What do you want to take into the exam with respect to this? Number one, which receptor will insulin bind to? You now forget this. That is dangerous. No one will forgive you. And that is tyrosine kinase receptor. So the insulin receptor has this tyrosine kinase activity. So it has this tyrosine kinase activity. So never forget this tyrosine kinase at all. Are we together?
Yes.
Yes. Yes.
Okay, please let's be together just for the meantime. All right, so that we have a long way. This is just the second system. All right, so that is tyrosine kinase. They will ask this in the exam. They will test it. You will know that the question is about insulin because they will mention it. Just say the activity of this hormone is through which of the following receptor, or the receptor that this hormone acts on as which of the following activity. The answer is tyrosine kinase. Just tyrosine kinase. Just note it, and that's all. So what are the we have what we call insulin dependent glucose transporter. We have insulin independent glucose glucose transporter. You can look at them like that. So insulin dependent glucose please watch out for look at this. Pay attention here very well. So insulin dependent glucose transporter, it means that before glucose will enter into this tissue, we need insulin. What are the two? The first one is adipose tissue. The second one is striated muscle. So which transporter is that? GLUT4. GLUT4. So you must write down GLUT4 and remember adipose tissue and striated muscle. So there is something about exercise. Exercise as a way of increasing GLUT4 expression. Relax, let me tell you more about that. That is the reason why a patient that is actually diabetic, one of the recommendations you give to them is be doing exercise. The essence of the exercise is not because you want them to be, you get. One of the reasons for it is that you want to increase their peripheral tissue sensitivity to insulin. How? When they do exercise, they express more of GLUT4, which will remove glucose from their body. So the glucose will enter from their blood. The glucose will enter into those tissue, adipose tissue, striated muscle, and the level of the glucose will drop. Exercise. So exercise increases GLUT4 expression. What about the other glucose transporter? We have 1, 2, 3, 5. You don't need to give yourself a headache. Please just note this GLUT2. You will know peace. Why GLUT2 and miss the rest? GLUT2, you see it in beta islet cell and liver, kidney, GI tract. Now, the thing about this GLUT2 is that it is insulin independent. It doesn't need insulin. Think about it. Do you think islet cell that want to produce insulin needs insulin before it's going to produce insulin? Do you think oh my God, I don't know how to put it. I don't know how to relate it in real life, but opposite is the case in the real life, because people that are wealthy, I don't know how to put it, like before you give out, you need to collect from the poor before you even give to the poor. And I think there are some programs like that. It's not right biologically, because here, beta islet cell, they are supposed to produce insulin. I don't need insulin before I will produce the insulin. So glucose just need to come and enter into them, and they should be able. Let me ask them, islet cell, beta islet cell. Glucose just need to enter into me directly. I don't need any. I just need to see and just start producing insulin. Not that I will. If they need insulin to release insulin, something is wrong, because they will stay there for long. They will stay there for long. They won't produce anything. So you call them this transporter. They call them insulin independent transporter. They don't need insulin to function. So through them, glucose will just enter straight into the islet cell. And very good example. Then liver, the kidney, the GI tract just enter into them, and they are fine. So never forget that GLUT2 is insulin independent. They will ask that in the exam. All right. One of the cell in the body that just utilize only glucose is RBC, red blood cell. Just for you to notice, they lack mitochondria for aerobic metabolism. Is there any other point you want to note here? It's about this guy. Unlike glucose, insulin does not cross placenta. This is applicable. You're going to apply this concept when you are answering question about why do you think we have a macrosomic baby from a mother that is diabetic. So this is the mother that is diabetic that is carrying the baby. The baby is inside. All right. So the baby is inside the mother. The mother is diabetic. So the glucose inside the mother will be moving to the baby. The baby will be having high level of glucose because glucose can easily move through the placenta from the mother. So when the glucose gets into the baby system, the pancreas of that baby will now be like, this glucose is too much. They are now going to start developing, they will start producing a lot of insulin. A lot of insulin in response to that high level of glucose. So to continue to meet the demand, to be able to suppress the high level of glucose in that baby, they will in fact they will start becoming hyperplastic. Like they are start like hyperplasia of the pancreas will start setting in, because they are now getting used to it. They need to push out a lot of insulin. Now, what are the function of insulin? I will use this opportunity to talk about the function of insulin. You don't need to cram the function. All you need to remember is insulin builds. Building in any capacity that you can think about building, think about it. So insulin will build. So in the course of building, the baby will start becoming big and big. The baby will now become macrosomic. We thought that is actually where the problem will end until the baby is born. And those pancreas continue to still push out those insulin at that high level. At that high level, they will still continue to push those kind of insulin out. So how are we going to address the problem? The best way to actually, because when they are born, that high level of insulin, don't forget that you've already cut away the placenta. The glucose in them is not as high as they used to be in utero. So they will now be lapsing into hypoglycemia. You just hear that. The baby in this also, I don't know how they used to name it again. So it's now developing hypoglycemia again. No, it's hypoglycemia again. So how are you going to tackle it? We need another hormone. Actually, you can give them glucose. After a while, they will grow and overcome it. But you need another hormone that can counter that hypoglycemia if it's not correcting on time. A very good example is glucagon. So glucagon, because there is a balance that exists, just for you to have an idea of what usually exists in utero, they may have a particular algorithm that they use to manage it, but just for you to see how glucagon can also play a role in the management there. So now, a mother that is actually diabetic, so you can help the mother by giving the mother insulin. It's one of the drugs that you can help, you can give to that woman. And that insulin does not cross the placenta. It shows that the baby will not be affected while the insulin is maintaining the glucose level in the mother. So please never forget that, just for us to note that. And that's that about that. Let's look at regulation here. How are they going to test the regulation in the exam? Now, insulin is the major regulator of glucose is the major regulator of insulin release. That's a fact. Glucose is the major regulator of insulin release. All right. There are two things they are going to put in graph. They will give you a graph. And the way you analyze the graph, let's look at it. So, because when there is a difference between oral glucose and intravenous glucose, oral glucose is going to increase the level of insulin that will be produced. Intravenous glucose is also going to cause increase in insulin release. However, the increase you will see in oral is more than the one on intravenous. What is that hormone that is making oral glucose to produce more insulin compared to intravenous? They will test it in the exam. The hormone is incretin. Incretin increase insulin release. Shikena. Another name for this incretin is glucagon-like peptide 1. Glucagon-like peptide 1. Never forget this, because glucagon, the way the glucagon is the way the glucagon, how do I put it, function. Maybe there is a similarity between, I don't know why they call it glucagon like that. Just for you to know that that's another name in case you see it in the question. Another name that they may call it is glucose-dependent insulinotropic polypeptide, GIP. But never forget incretin. So they will give you a graph. Let us imagine how the question can be tested. They give you a graph. They call this insulin level and they call this, they now say that they notice that maybe the first one is like this, the second graph is like this. So what do you think is likely response? This is oral glucose. With oral glucose, this is how the insulin level rises. This is with intravenous glucose. They can now ask you that which hormone do you think is responsible for the significant increase in the oral glucose level, increase in insulin with oral glucose administration. So the hormone you'll be looking for in the answer is incretin. So that is the reason why a patient you are managing for diabetes, you want to commence them as soon as possible on oral diet. Because with oral diet, it's also going to, instead of you to maintain them on intravenous fluid and be like, take GKI, you want to switch them as soon as possible to oral diet, because with the oral diet, they will produce more insulin than what you will just be administering insulin. You need to quickly switch them. Once you take them out of the emergency state, you switch them to the normal diet, because with the diet, they will be able to release incretin that will also raise the level of insulin demand. So that is how this incretin will be tested. So watch out for questions that look like this, or anyhow that the thing may shall resemble this. You have an idea. What else do you want to note is about the receptor. The receptor that regulates the way insulin is released. So we have two receptors, and thank God the way those receptors are. They are just alpha 2 and beta 2. Alpha 2 for life, never forget it, for life is inhibitory receptor. Alpha 2 is inhibitory. Alpha 2 is inhibitory for life. Anywhere you are going to be looking at it, just say inhibitory. So if alpha 2 is inhibitory, if you stimulate alpha 2, definitely there should be, by alpha 2 with respect to the pancreas should actually reduce the release of insulin. What about the beta 2? Beta 2 is better. It's actually going to cause increase in the release of insulin. So there is a way they can test this receptor. Anyhow, just remember alpha 2 is inhibitory, beta 2 is better at stimulating release of insulin. What's the last thing we need to talk about here is this diagram. You can't go into the exam and not master this diagram. It is a sin not forgivable under the United States Medical Licensing Examination Step 1, 2, 3 law. Don't want to forget it. So what is it about this diagram? How the insulin is released. We mentioned GLUT2. that these are insulin, they are what do you call it? They do not depend on insulin before they are going to allow the glucose to actually pass through them. That is GLUT2. They are insulin independent. They don't need insulin to allow glucose to pass through them. So this patient has eaten. The glucose level is high in the patient's blood. Glucose will now enter through this GLUT2. They will ask it in the exam. This is a pancreatic cell. Glucose will enter into this through this GLUT2. Immediately it gets into this beta cell, is going to undergo glycolysis. What will glycolysis do? At least you've heard about glycolysis before. Glycolysis will release ATP. So ATP ratio ADP will now be high because you now have more ATP than ADP because more ATP are produced from glycolysis. This ratio, you forget it at your own risk because they will ask it in the exam. What is the significance of this high level of ATP in the patient? This high level of ATP will come to potassium channel and block it. So when it is blocked, potassium can no longer leave. Because this is actually ATP sensitive potassium channel. So if the ATP level is high, it will close. As it is closing, potassium will start accumulating. Do you get me? And that is going to cause depolarization. The depolarization you see here is going to cause calcium channel. You call it voltage gated calcium channel to open. As this voltage gated calcium channel opens, calcium will flood in. There is one function of calcium you must never forget with respect to vesicle in all these cells. When calcium enters in, is going to cause vesicle containing all these molecules to move towards the membrane. So the vesicle containing the insulin will come towards the membrane, fuse with the membrane, and release the insulin. So we now have high level of insulin in the blood. The next reaction, so never forget this high level of ATP ADP. They will ask, by what mechanism do you think the potassium channel is closing? High level of ATP, because this is a potassium channel that is sensitive to what? ATP. So it's going to close. All right. So insulin is in the patient's body now. It's now going to move to insulin dependent glucose tissue that contain insulin dependent glucose transporter. A very good example, skeletal muscle. Another example, adipose tissue. So we come to the skeletal muscle now. Insulin has come there. So what will happen? Insulin will bind to its receptor. Its receptor is having tyrosine kinase what? Activity. Kinase is kinase anywhere. It phosphorylates. And that is going to cause phosphorylation of tyrosine. It's a sin when you forget this. So tyrosine will be phosphorylated. Phosphorylated tyrosine is going to help with all manner of processes. Cell growth, DNA synthesis, glycogen synthesis, proteins. Can you see the way insulin is now executing its function? For growth, building. Another function is going to do is to cause this vesicle containing GLUT4 to move towards the membrane and insert themselves on the membrane. So more of GLUT4 will also be expressed. So more glucose will now enter into the system and start helping with this synthesis that is ongoing. And that is how this will help. So never and never forget this. That's why we say you need insulin to move glucose through this transporter. All right. So never forget tyrosine kinase activity of the insulin receptor. They will ask it. Don't wake up. Sleep well. There's no motivation for you. we are motivation has finished.
Who is sleep?
His motivation is no, we don't have motivation again. Just sleep and wake up. When you sleep, you make, maybe the next time you'll be waking up. We're already on page 26. So sleep well. All right. So let us look at simplicity of congenital adrenal hyperplasia and adrenal steroid. have. All right. So look at adrenal steroid and congenital adrenal hyperplasia. How are they going to be testing this in the exam? You see this table? If you cram it, you are only deceiving yourself. You cramming it does not mean you will be able to answer the question. Relax, sit back, and see the simplicity of it. All right. So anytime you read a question that you know that this is dealing with all this adrenal hormone, or they want you to diagnose what is going on with the patient or to mention the enzyme that is deficient, how are you going to be looking at such question? All right. This is the first thing you need to note. We have 3 wonderful enzymes that you will be tested on here. Number 1 is 17 alpha hydroxylase. Number 2 is 21 hydroxylase. Number 3 is 11 beta hydroxylase. They are going to test this enzyme very, very well. So whether you like it or not, they will test them. So 17 alpha, 21. So you can arrange them in a descending order. 1 plus 7 will give you 8. 2 plus 1 will give you 3. 1 plus 1 will give you 2. Just arrange them. So you will know that, okay, which one is which one is the first one. So you won't be shouting, I shall remember 11, then 17, then 21. That is not logical. You won't really be able to answer questions very well like that. This one, you don't need to cram anything. This is the first thing I want you to note. Now, 17 alpha is actually, when you see the way the body think is that we have this molecule. Let me just call it pregnenolone, the way they've written it. The molecule here. Look at the molecule here. So you can either go horizontally or you come down vertically. So if I want to go horizontally, I will be going towards androgen. That's how I go. All the molecules they put there, don't bother. If I'm going to come down vertically, I will be coming towards something like the aldosterone, then cortisol. All right. So this is the first image that must be at the back of your mind. Horizontally towards the aldosterone, vertically towards the androgen, vertically towards the aldosterone and cortisol. So you will now look at that question. Are there evidences of elevated level of in this? The reason why they call it congenital adrenal hyperplasia is actually because cortisol is low. That low level of cortisol is low in all of them. That low level of cortisol will make ACTH to be produced more. ACTH will now come back to act on the adrenal gland, adrenal cortex, and cause hyperplasia. Adrenocorticotropic hormone. They actually respond to the hormone by growth. So there will be hyperplasia, and that is where it's coming from. So if it asks in the exam, what do you think is the origin of the hyperplasia? The answer is high level of ACTH. That is what is causing the hyperplasia. You now look at that question. Which of these hormone is actually high? If androgen will be the answer of the hormone that is high, I will see features of androgen being high in the question. This is a baby. Now look at it critically. This is a baby. Let us assume that this baby is just 4 years old, and the baby is a male. So if this baby is a male with 4 years old and is having high level of androgen, you will be seeing features of adult in that baby that is a boy. Because boys normally they should have androgen, but this is a baby. If this baby is having high level of androgen, the baby will start growing sorry to mention that, growing bare at 4 years old, start having acne. The phallus may even be a bit big, and some other features that you may be able to. So you call all those ones something that look like precocious puberty. The age might not be that small that they are going to give. So it shows that androgens is high. Do you get it? So it's high. I already know the hormone that is high. Once I can bring out that this is the one that is high, until proven otherwise, the enzyme that is deficient is actually related to this fatica. So let me reiterate that point for you to understand. This is where you see 17 alpha enzyme. This is where I'm going to see 21, and the one beneath it is going to be 11. So the way the body think is that if enzyme in this fatica is deficient, any of this is deficient, body will channel most of this pregnenolone to the part where there is no deficient enzyme. So most of this pregnenolone will now be converted to androgen. So immediately you read the question, you just see high level of androgen. Just let the diagram come, so just be like, my deficient enzyme is either 21 or 11. It's just as easy as that. So we are now going to use another molecule to separate 21 and 11. If this baby is a girl, and this baby, how will I know this baby that is a girl and how will I even know this baby is a girl? The question will mention the karyotype. They will mention it. Karyotype. You say that the karyotype is XX. Immediately you say that karyotype is XX, then I'm dealing with a girl. They now mention that the clitoris of that girl is big. They won't mention it like that. They will say there is clitoromegaly. The clitoris is as big as a mini phallus. Clitoris is as big as mini phallus. Then the labia majora, the minora, and the likes, they may not as develop the way they should, to the point that they may even be looking like you are dealing with a scrotal sac. So you can look at that one. So you can just, when you check the question, you will see features of high level of androgen in that patient. Anytime you are dealing with a girl, that patient is a female that is now having high level of androgen, you say that patient is virilized. You talk about virilization with respect to a girl that is looking like a man, like a boy. You don't make reference to virilization with respect to actually a male, until I don't know how true that grammar is. But girls that are looking more like male, you say there is virilization. That is with androgen. So which enzyme is deficient? It will be related to these two enzymes, fatica here. Merely reading the question, you just start seeing features of high level of androgen in the question. You already know that most of these substrates, they are converted to androgen because there is a blockage, there is a deficiency of the enzyme of one of these two enzymes that are related to the fatica. Shaken up. All right, we've seen that. Let us look at these two enzymes. How are we going to know which one is which? God is wonderful. The first enzyme you see here is 21. The duty of 21 is to produce a substrate that 11 will act on. Which substrate is that? Don't forget I say we are not going to cram anything. We shall know that in the nomenclature in science, you can actually use the substrate to know the name of the enzyme. All right. So the substrate that this 11 beta hydroxylase is actually going to be acting on. I mean, the hydrogen is going to be acting, hydroxylase rather, is going to be acting on is this one. Sorry. So this is how you look at it. This is 21. This is 11. So, sorry. So 21 is going to produce a substrate. Sorry. 21 is going to produce a substrate that this 11 beta hydroxylase is going to be acting upon. So which molecule is that? We'll call it 11 deoxy. I don't know the full name. I shall know 11 deoxy. So this is the only molecule I want you to remember with respect to the Fatica. Just 11 deoxy, 11 deoxy, 11 deoxy. So what this means is that, think about it. If 21 is deficient in the exam, 11 deoxy will be low. If 11 beta hydroxylase is actually the one that is deficient, 11 deoxy will accumulate. By looking at the question and you are seeing 11 deoxy alone, you already know the enzyme that is deficient. So they will give you the stuff. They will just say that they notice 11 deoxy. Deoxy what? They will put corticosterone is elevated. Once immediately I see that it's elevated like this, then it shows that 11 beta hydroxylase is not there to convert it to the next molecule. If 11 deoxy is low, it shows that 11 deoxy is not formed by the 21 hydroxylase shikena. So that is how you will be knowing which of these two enzymes is there just by looking at 11 deoxy. It's just a mathematical expression. If the level is high, it shows that this enzyme is working well to form it. If the level is low, it shows that if it's high, this enzyme is present to form it, but this 11 is absent to convert it to the next one. So if the level is low, the possibility is that 21 hydroxylase is actually deficient to form it. Just be looking at that for in the exam. So just look at whatsoever they are going to give you and check what is the level like. I may give you an example just for you to have an idea of the way the question will come. All right. So that is this molecule. Is there another thing about this molecule? Another thing about it is that if the level is high, is actually regarded as a weak mineralocorticoid. It has a mineralocorticoid effect, but it's weak. So what is the function of mineralocorticoid? They will reabsorb sodium and throw out potassium and hydrogen ion. So it shows that if 11 deoxy accumulate, the patient will have hypokalemia. The patient will have hypertension from reabsorption of sodium. The patient can have metabolic alkalosis from throwing out of hydrogen ion. So just by seeing this one accumulate. So never forget this at all. All right. And if at all you see the level is low, you know opposite is likely going to be the case. So that is how you'll be separating the deficiency of 21 from 11. I will show you, give you an example. You will practice and flex your muscle on it. So look at this 17. Let us assume that 17 is the one deficient. What are we going to be seeing in the question? You just start seeing most of the androgen effect. Androgen level is going to be low, number one. And you will be seeing majority of mineralocorticoid effect will now be more pronounced. It will be pronounced. Like pronounced mineralocorticoid aldosterone is, because this is actually the one that is deficient. Most of this molecule will now be coming down through this channel. So it shows that the enzyme, the enzyme that is deficient is 17 alpha hydroxylase. All right. Which molecule are we going to see in the question that will tell us that 17 alpha hydroxylase is deficient? Just 17 alpha molecule something. A very good example is 17 hydroxypregnenolone or 17 hydroxyprogesterone. Just 17 hydroxy something. 17 hydroxy something. So you just see that the level is low. You show that the enzyme that should form it is actually deficient. And that's, just remember this. And remember 17, 21, and 11. All right. So that is how you are going to be looking at it. What are the examples of androgen? DHEA. You may note the example in case they list them. These are the examples: dihydroepiandrosterone, androsterone, testosterone. These are the example of the androgens. So they will put them in the question for you. So that's all. You don't need to, other than for you to note the enzyme, the vertical, the horizontal, and 11 DLC in between 21 and 11. 11 and 70 hydroxy something for the androgen side. I think those are the basic things you want to note with respect to this area. So the order, you will be able to find your way around it. Before I go to questions to show you around, androgen can be converted to what do we call it? Estrogen. Estrogen, you see it in female. You can, major female secondary sexual characteristic hormone. All right, so that's estrogen. The hormone, when you see female aroma and the like, something aroma, at least when some female pass, they have good aroma. You can look at it like that. So aromatase. So for the testosterone, the most active form of androgen is dihydrotestosterone. So this dihydrotestosterone, most of the time you see it in the it's actually formed in the peripheral tissue. So the enzyme that's going to help its formation from testosterone is 5-alpha reductase. Testosterone to dihydrotestosterone. This is the most active form of it. So never forget the difference between testosterone and dihydro. So let us flex our muscle with 2 or 3 questions, or 1 or 2 questions. I just want you to have an idea. It's not about whether you get it or wrong. The answers are there. So, but just for you to see the way those questions play out for you in the exam. I have a lot of questions, but you don't need them. They are just the same set of questions you have in your question bank. So I want you to look at this. A 13-year-old girl is brought to the clinic by her mother for a yearly physical examination. The patient feels well, but is worried that she has not yet started puberty. Temperature is 36.7. Blood pressure is 152/91. So first thing first, this merely checking through the options, you'll know that you are dealing with all this adrenal issue. So you now see blood pressure is high. Quickly note it down. There is high blood pressure. Sorry. So you can also get a paper so that you won't mess up the analysis. So there is high blood pressure. You just write high blood pressure down on the small paper they will give you in the exam. The pulse is looking good, respiration looking fine. Physical examination is significant for a lack of secondary sexual characteristic. So there is deficiency of secondary sexual characteristic. Where is it supposed to come from? This is someone that claim is a girl. So this is gender. You just write girl for now. Don't forget that you still need to verify it through the you still need to verify it through the karyotype. They are likely going to give the karyotype in the exam. Alright, so deficiency of secondary sexual characteristic is there. So what do you see? A blind vagina is noted on pelvic examination. Laboratory study revealed hypokalemia. So we show that potassium is actually low. The next thing is low testosterone and estradiol. So testosterone is low. Estradiol is also low. So cytogenetic analysis shows 46XY karyotype. It shows that this patient is actually a boy. This patient most likely has deficiency of which enzyme? You just look at it. Just if you draw your stuff like this, you just draw something like this in the exam. So for us to have IBP, for us to have low potassium, it shows that the enzyme that are related to Fatica are doing well. That's your assumption. You just look at it like that. That's your first. But for you to confirm that, look at the androgen. Is the androgen high or low? The testosterone they gave here is low. Estrogen is supposed to, they are supposed to come from the testosterone, at least from with respect to the adrenal. Do you get it? So, and they say they are low. So there is low. You can look at it and just say low androgen. So for the androgen to be low here, this is where the deficient enzyme is located. So majority of the molecules that are here, they are channeled towards this fatical axis. So where aldosterone mineralocorticoid are produced, no wonder the BP is high, the potassium is low. All right, and the karyotype of this patient is a male. So therefore, the simple question they ask is that which enzyme do you think is deficient? Your answer will now be 17 alpha hydroxylase. Shikina. All right, so that is how that is going to be. I want you to try this question. This is a question I want all of you to try. We'll read it together. Then you don't need to look at the option. Just look at the heading of the option and you mention it. This is a 2.8 kg newborn who is delivered at term to a 44-year-old woman. Don't worry, just relax. Pregnancy and delivery were uncomplicated. At 10-week gestation, the patient underwent cell-free fetal DNA testing, which showed a low risk of fetal aneuploidy and XY fetal sex chromosome. Examination shows infantile female external genitalia. So the first thing they are telling us here is that, well, this is someone that is XY. That's the first point. The second point, you're also supposed to be analyzing because you'll be the one to bring out the answer. The second point is that the patient is having infantile female external genitalia. All right. Serum studies show a reduced level of 17 hydroxypregnenolone. You don't remember where the molecule, but you remember 17. Definitely is related to androgen side. So we'll now write something like this. So it's decreased. So there is reduction in androgen. All right, just put something like that. Which of the following set of changes is most likely found in this patient? So if there is reduction in androgen here, where do you think the deficient enzyme is going to be? Anyone? What do you think? Which enzyme do you think is deficient?
17 alpha hydroxylase.
70 alpha hydroxylase is likely deficient. Shikina. So which enzyme activity do you think is going to be high?
21 and 11 alpha.
Right, people are just rumbling some answer. Right? Actually, I want to
21
believe that.
hydrogen and 11 beta hydrogen.
Exactly. So those two other enzymes, their own activity will now rise. So which of these options do you now think is likely to be correct?
D.
So what do you think will happen to BP? Just tell me high or low.
C.
High.
What of potassium?
Potassium will be low.
Potassium is low. BP is high. What do you think will happen to cortisol?
Cortisol will be low.
Cortisol is low. Lovely. So let's meet our mics. So definitely from the answer you echoed, BP, you say BP will be high, potassium will be low, cortisol will be low. So which one is that? High, low, increase, high, low, low. So your answer is C, right?
Yes.
Okay, let's check. You got it. So I want to answer one more before we go. Look at this one. Let us mute our mic. Let me read it for you and you do analysis. I will just tell you to unmute your mic so you tell me either A or B. This is an infant who is born at 39-week gestation to a 26-year-old woman. The delivery was uncomplicated and Apgar score was 8 and 9 at 1 and 5 minutes respectively. The mother had gestational diabetes during pregnancy, which was controlled by diet alone. Physical examination of the infant showed clitoromegaly. So let's note it down. There is clitoromegaly. There is also partial fusion of labioscrotal fold. All right. Then they do the cytogenetic analysis showing that we are dealing with a female, XX. Abdominal imaging show bilateral adrenal hyperplasia. This patient is most likely deficient of an enzyme. Which enzyme is that? They say which the enzyme is responsible for a particular conversion. And Festus say don't cram any of these. Now they are bringing conversion. Let us see how easy it will be. So this patient has clitoromegaly. This is a female, clitoromegaly, partial fission. Definitely the androgen level is high. So that's how we look at it. The androgen is high. Just put it here. It's high. If androgen is high, definitely the what do we call it? Its name. Definitely the mineralocorticoid is going to be low. All right. How? Because if this one is high, the enzyme that is deficient is going to be related to this area. Can you see? This is where the enzyme that is deficient is. Okay. Now, I want you to pay attention to the analysis I will do here. Because there is a point I will mention that I've not mentioned before. All right. So there is, this is where the enzyme that is deficient is. So my answer is either related to 21 hydroxylase deficiency or 11 beta hydroxylase deficiency. Which one will you go for? In the exam, amidst all the three enzymes I have mentioned for you, the most common one that is usually deficient is 21 hydroxylase. So with that statistic, I already know that my answer will be 21 if I'm contemplating between 21 and 11. Why do I need to be contemplating? The reason is because there is no any other information given to me that I can use to tear two of them apart. I can only resolve to statistic. 21 is the most common enzyme in all these congenital common enzyme deficient in congenital adrenal hyperplasia. So I already know 21 is deficient. So if 21 is deficient, which molecule did I say is not going to be formed? And that is going to be 11-DOC will not be formed. Abi? Yes. 11-DOC is not formed. I already know the... So they now ask me that the reaction, they say that this patient is most likely deficient for an is likely deficient for an enzyme normally responsible for which of the following conversion. The enzyme must be forming. The reaction must be giving a product of 11-DOC something. So I will now come to option. Which of these is leading to 11-DOC something? The only answer you see here is C. That's the only one that's leading to 11-DOC corticosterone. So therefore, my final answer is going to be C. So I will now come and if you are still rehearsing, that's correct. Just pick that and go. So never forget the way we've done the analysis. You can, what I'm going to do is that I will just show you the question, the remaining question and the answer. When you are solving or listening to the video, you can look at them. Like in this question now, they are asking for maybe what do you think is an issue as an appropriate intervention initiated, targeting which hormone. So you can easily answer this. All right. Look at this. Okay, let us try to solve this one before we go. Just for you to see the way they all play out. I want you to also look at it and bring out the answer. A 6-year-old boy is brought to the physician by his mother, who is concerned about his early sexual development. He has no history of serious illness and takes no medication. All right, which concern do you have, madam? He is at 99th percentile for height and 78th percentile for weight. His blood pressure is 115/78. All right, let us just note down the BP 11578. But this does not look high to me. I may be wrong, but this does not look high. Okay, so examination shows greasy facial skin. So let's note it down. Greasy facial skin. Cystic acne. Cystic acne on his forehead and back. There is coarse, axillary, and pubic hair. They now give us this serum stuff. Cortisol is given. So which in the exam you just need to check is it high or low, which I want to assume is low. They now give us DOC corticosterone. DOC corticosterone. So they are giving us this, which is actually 2.5. This DOC corticosterone is lower than normal. Sorry. It's lower than normal. Now look at the dihydroepiandrosterone sulfate is higher than normal. Now relax the way you will go about it. At least you can see androgen here is higher than normal. Definitely the androgen is high. The androgen is high. Shaking up. That's the first thing. All right. Sorry. So the enzyme that is deficient is going to be related to which one? It's going to be related to the fatica. It's either you are dealing with 21 or you are dealing with what? 11. All right. So check the question. Do you think the blood pressure of this patient, the blood pressure of this patient, do you think the blood pressure is high? It's not actually high. The blood pressure of this patient is not high. I think the reference BP for all these children is, you start thinking that it's high when it's above 130 over maybe 80. I may be wrong, you can confirm that. But I think it's when it's above 130 over 80 is when you say the blood pressure is actually high, most especially for those that are less than 13 years. So I may be wrong, but try to confirm. So this blood pressure is not high. So immediately I see that the blood pressure here is not high. Definitely this 11 DOC that is supposed to be here is actually not accumulating. It's going to accumulate. Do you get me? Because it's a weak mineralocorticoid, it's going to accumulate if this enzyme that should convert it is deficient. But it's not accumulating. So this is not the enzyme that is deficient. So it means it's not really formed, which you can confirm from this. Even though they do not put 11 there, this is still the same molecule. DOC corticosterone. 11 DOC, DOC, 11 DOC, DOC. So it's the one you can see is low. So 11 DOC is low. It shows the enzyme that is deficient is 21 hydroxylase shikina. How many people got it? Did you all get it? Dr. Juliet got it too. Everybody got it. Okay, that's fine. So we'll leave it there. You can go and let me flip the remaining. You can go and check them up. Can you see? Just go and check them up and apply the principle. You will be very fine. You can see they are even giving you potassium here. You can apply it just for you. All these molecules will not be, you won't be scared again. You already know where they belong. This one too, you can go and apply that. This is another one. This is the last one. All right, so we are going to leave that one there. So you don't need, this is it. So 11, 17 hydroxy, if they are giving you all those table questions, you can answer them. 21 hydroxy, you can answer them. 11 beta hydroxy, you can easily answer them and bring them out. So fertilization with respect to female, fertilization with respect to female, that will really make a lot of sense. All right, now all of them, they are autosomal recessive disorder. Forget this at your own risk. All of them autosomal recessive. So all these mnemonic they are giving you, if the deficient enzyme starts with 1, forget it. You don't need it. You need to look beyond just if deficient enzyme starts with 1, and you don't need all those stuffs. It's quite easier to do. Let me give us, permit me to, though I used to do some stuff, but you won't be angry with me. It's just for our own good. So someone asked a question about 17 alpha hydroxylase. And which one, sir?
Like the flow, just the flow of the 17, 21, and 11.
That's more or less like you want us to go back. I think
Yes.
when we listen to the video, you will get it actually. I think we were quite slow on it. Okay, let's start with this cortisol. So now, the thing about the cortisol, you don't need to cram much up just for you to pick 1 or 2 points and move on. There's really nothing much. The first thing is about the effect of cortisol on blood pressure. So cortisol has a way of upregulating alpha 1 receptor on the artery. You can't go into the exam and forget this. It's not allowed. It's not allowed. So you need to note this. So what it does is actually upregulating alpha 1 receptor so that the endogenous catecholamine will be able to act on those receptors. Have you wondered why that patient that is having hypotension or that just go there and you are shouting, hydrocort? So what is the hydrocort going to do? Is it that the hydrocort is the one that will help to raise the BP or what? What the hydrocort actually does is to upregulate the alpha 1 receptor on the arteriole so that the endogenous catecholamine will have more receptor to act on. So please note this one very well. It's going to really help. The cortisol also has a way of increasing insulin resistance. That is the reason why people that are on steroid, that takes maybe steroid containing cream and they've been using it for long, they can easily become diabetic. Cortisol has a way of reducing fibroblast activity. That's why when you operate on those that have been on cortisol for a while, as the way when you are even cutting through their skin is not really looking that healthy. So all because their skin does not really contain enough collagen as such. Most of the collagen that should have been synthesized they are not really there. Then they can also have all manner of striae. So after even operating them, they have poor wound healing. So that's with respect to fibroblast activity. All right, thank you so much. So what else do we need to take into the exam with respect to cortisol? And that is the effect of cortisol on the inflammatory and immune responses. So cortisol as a way, they will ask you this question in the exam. It's one of the most tested concepts in the examination. Cortisol has a way of causing neutrophilia. It can cause neutrophilia. They will now ask you that by what mechanism. Cortisol is going to cause what you call demarginalization of the neutrophil. This is the first one. Those neutrophils, they are here. When they want to, so you have some of the neutrophils that will be marginalized to the vessel wall. They can now be undergoing their rolling and all manner of stuff before they eventually find their way into the tissue that needs them. All right. So it shows that we have some neutrophils that are already on the wall. So what the cortisol or steroid is going to do is to cause majority of the neutrophils that are on the wall, now cause them to leave the wall and come to the blood and come into the blood and leave the wall, come into the blood. So if they are coming into the blood, it's not going to look like the patient has neutrophilia, like there is increase in neutrophil production. It's a lie. It's actually because of demarginalization of neutrophil. I hope that is the correct pronunciation of that word. All right, so never forget this. So you say neutrophil is inhibiting WBC adhesion. So they will ask this. This is one of the most tested concepts in the exam. So just for you to note, I mention all these most tested concepts so that in the exam, when you are seeing them, they are no longer new to you. You are already used to them. So other things that the steroid can cause is actually eosinopenia, lymphopenia. If you look at the order, they are just penia. It's only this one that you have neutrophilia. That's why you need to note it very well. Another important concept is with respect to interleukin-2 production. Neutrophil is going to block interleukin-2 production. So because neutrophil is going to block interleukin 2 production, so the patient, interleukin 2 is one of the molecule, interleukin 2, interleukin 12, interferon gamma. They are actually all important in the formation of actually what do we call it, granuloma. All right, so if there is a reduction in the level of interleukin 2, so there may be reactivation of TB and also candidiasis, because if at all there is already form what do you call it, granuloma, it can actually break down in a way. Just for you to note this interleukin 2 with respect to steroid. All right, you already know how you regulate it, cortisol. So if at all the cortisol level is high, by negative feedback, there will be a reduction in the ACTH. There will also be a reduction in the CRH also. So please never forget the negative feedback. So you come down to the appetite regulation. So we have these three guys. Most importantly, these two guys, ghrelin and leptin. So look at the name. Ghrelin is actually going to make the patient to grow. Grow how? Hungry. When you are hungry, you eat. When you eat, you grow. Ghrelin, when you eat, you grow. So ghrelin will make you and I to be hungry. When we are hungry, we go and look for food and eat. Then we grow. All right, that is what ghrelin will do. Leptin will make the patient to be thin. So how will it achieve thin? Will not make the patient to be hungry. When you are not hungry, you are not eating. Never forget that. When you are not hungry, you are not eating. So please, I want you to note this and get used to it. All right. With respect to ghrelin, where is ghrelin produced from? Ghrelin is produced from the stomach. You can be asked. 1 minute, please. 1 minute. All right. Sorry. So now, where is this ghrelin produced from? From the stomach. So never forget it. Now, there is something you need to note very, very well. Like, you go and forget. I don't even know how to put it. 1, where this ghrelin will act. Number 2, the condition that is likely to be linked with this ghrelin. All right, please never forget this. Number 1, this ghrelin is going to act on the lateral area of the hypothalamus, where you have the hunger. I used to make one illustration, and the illustration is that as I'm talking now, when you are hungry, you can't focus on your screen. You will be looking laterally. You can't focus when you are hungry, and that is the concept. So if I thought they hacks, you already know that ghrelin will make the patient to be hungry so that the patient can go and eat and grow. So if this ghrelin is going to act on the hypothalamus, which part of the hypothalamus is it going to act on? The lateral nucleus. So never and never forget it. This lateral area of the hypothalamus, never forget it. That's where you can ask that. So when it's acting on it, it's going to stimulate appetite and the patient will go and look for food. Which condition can they link to ghrelin? Where you have ghrelin overproduction, and that is Prader-Willi syndrome. You forget this at your own risk. The patient, they have a lot, they are hungry. They eat like anything. Also in this one, you have increase in ghrelin production, so they will be hungry most of the time. You need to give them food from time to time, so they end up becoming very big. So they have this obesity because they eat a lot. Then fasting, people that fast too, and like, just note this Prader-Willi very well. And like, so what about the leptin? If leptin will actually make you to feel like you are okay, you are not hungry. All right, so where is leptin produced from? They will ask you in the exam. Leptin is produced from the adipose tissue. Oh, thank you, Festo. So that leptin comes from adipose tissue. Yes, it's from the adipose tissue it actually comes from. All right, the thing about it is that people that are obese, they are supposed to produce a lot of what? leptin. Now that is where USMLE will now add for you. So if people that are obese are supposed to produce leptin, this is obese patient. So you're supposed to have a lot of leptin in our blood. So this leptin, they are supposed to make the patient to feel satisfied and not hungry. But look around you, those obese people you see around you, they actually eat a lot. Why? Is it that their leptin, they are not producing leptin or what? They actually produce leptin. But continuous exposure to high level of leptin will make their, what do we call it? We make the ventromedial area of the hypothalamus not to respond to it again. The ventromedia is the area that of the hypothalamus that the leptin will act. It makes you to be focused. So when you are satisfied, you can concentrate medially, ventromedia area. So that area is continuously being stimulated by the leptin. So because of that, they become tolerant to it. So they won't be responding. Be like, the leptin is always high. So you won't now see effect of leptin in them. You'll now be seeing opposite of it. That's why you see obese people that are supposed to be having this satiety, they are always hungry. You are seeing opposite of the normal physiology in them. So please never forget this. They will ask it in the exam. I think that's the main thing. Endocannabinoid can act on the cannabinoid receptor in hypothalamus and nucleus accumbens, and it can also lead to increase in appetite. All right, let's look at this signaling pathway of endocrine hormones. What do you want to take into exam with respect to these guys? These are the molecules. Majority of them you already have an idea. Glucagon, we've talked about it. PTH, we've talked about it. ACTH, though we've not talked about it, is one of the molecules that's actually hacked by through this CAMP. So either you are increasing or reducing, you shall know that their effect is related to CAMP. That's the main thing. So you just need to pick few of them, maybe ACTH, PTH, glucagon. You can pick those ones and move on. What of CGMP? You remember BMP, AMP. So another one is this EDRF. So endothelium derived relaxing factor, if I'm not mistaken. I think that's the EDRF. So it's also going to act through nitric oxide. So never forget CGMP. So very high yield to note. Then you see this IP3. You remember IP3 that we were mentioning the other time. H1. You remember half 1 hem and hem. Do you get it? So you can just, at least you can see histamine 1 here. Angiotensin 2 is also here. Alpha 1 receptor, you remember? So never forget that. Alpha 1 receptor is also part of the angiotensin 2 and the likes. So gastrin, gonadotropin releasing hormone, and the oxytocin, ADH, they all act through this IP3. They will just ask you, just mention. If you remember what I told you in cardio, this will not be a big deal for you. So now, where are you likely going to get confused? All right, you can get confused with respect to receptor tyrosine kinase and non-receptor tyrosine kinase. Okay, so receptor tyrosine kinase, at least from our exposure, you know that this is likely to be dealing with insulin. And apart from insulin, there is another hormone that behaves like insulin, and you call that hormone growth hormone. Growth hormone actually exerts its effect through a particular molecule, insulin-like growth factor. So I will summarize the receptor tyrosine kinase here, that just note growth factor and insulin. So when you read the question and you are seeing something like insulin-like growth factor 1, you just pick receptor tyrosine kinase. Fibrotic growth factor, platelet-derived growth factor, and EGF insulin, just pick receptor tyrosine kinase for all of them. Okay, so please never forget this. They can give you any molecule and just pick your receptor tyrosine kinase. If you can remember insulin, any other hormone that behave like insulin, you peg it on this receptor tyrosine kinase. What about the non-receptor tyrosine kinase? I just say these are related to blood cells, just related, just looking for a way to coin them. So, granulocyte colony stimulating factor, erythropoietin, thrombopoietin, prolactin, So you can see something related to red blood cell, platelet, and WBC in this patient. Then we have growth hormone here. Now you need to be very careful. So this can be tested in the exam. I mentioned growth factor here. Now here you have growth hormone. So in the exam they may give you growth hormone. In the exam they can give you this question. This question is like, don't forget that growth hormone acts directly on the adipocyte. So they can now ask you through which receptor, or the receptor is, or through which mechanism or something like that. So the effect of growth hormone on the adipose tissue is going to be via the non-receptor tyrosine kinase. Now, with respect to the other tissue, it's going to be via insulin-like growth factor 1, and that is via receptor tyrosine kinase. So these are growth factor, not just ordinary growth hormone. So you need to be very careful so that in the exam you don't just go and pick something that you are not supposed to be pick and be looking for the head of Festus. Now, the last, let me show you another important concept with respect to this area, and that is signaling pathway of steroid hormone. I gave you an idea the other time about the tyrosine binding globulin. You must never forget, I mentioned that you want to link it to estrogen. Once the level of estrogen rises, the secretion of that tyrosine binding globulin is also going to rise. And I summarize it that most of the binding globulin, their level will actually rise with respect to the level of the estrogen. So any patient that has high level of estrogen, you want to assume that the binding globulin is going to rise. Now relax. God is so wonderful. God did something miraculous here. God gave the female this hormone, sex hormone binding globulin. They've been binding guys for long. The female, it has been long they've been binding them. It's the power that is actually conferred on them. Sex hormone binding globulin in them, they have it, and it doesn't mean that you can relate it to the guys, but let's just focus on the female. So they have it. So if the lady actually has, let me say this is the lady. So this lady has a sex hormone binding globulin in her. So if this lady should actually have high level of estrogen, is going to have this sex hormone binding globulin increasing. So what can make estrogen to rise in this woman, in this lady? If the lady is actually a very young lady, number one, this lady is pregnant, number two, this lady is having is on drug that contain estrogen, number three. So the level of sex hormone binding globulin will rise. So this sex hormone binding globulin will now go to the blood, they are inside the blood, and bind most of those androgen, testosterone. So when they bind most of those testosterone, the level of free testosterone in that female, in that woman, that lady's blood is going to reduce. So that lady is going to manifest more as a female, because that will now give estrogen in her upper hand. All because sex hormone binding globulin has bound most of the testosterone, those androgen. Now think about it. Let us assume that sex hormone binding globulin is low in this lady. If it's low, the next thing you will see is that most of those androgen, testosterone, they are not bound to, they will not be active. If they are active, the female will now start manifesting like some attributes that you can peg on testosterone. A very good example is hirsutism. Their bear may even be longer than their husband. All right, that's just a joke, but hirsutism, acne, and all manner of stuff. So watch out for this sex hormone binding globulin in relation to estrogen. What about the male? You do not expect sex hormone binding globulin to be high in male, because this sex hormone binding globulin is just going to be binding to testosterone. So in a male, you don't expect it to be high, to be binding to testosterone. You expect it to be low. But what if there is now a reason, or by one reason or the other, the sex hormone binding globulin in that guy is actually high? If it's high, it's going to be binding most of those testosterone. That will now make the few estrogen that are there to now become more prominent, and the guy will start manifesting as a female. You start seeing something like gynecomastia and changing the pattern of hair distribution, pubic hair distribution in that guy. So never forget the way they can play around the sex hormone binding globulin. That's just the main thing you need to note here, and that's all. So let's come down to the pathology. You don't have much to cram here. The first important concept they want you to put at the back of your mind is what we call SIADH. What is it about SIADH? Syndrome of inappropriate antidiuretic hormone secretion. You already have an idea of what ADH does. If you now have high level of ADH performing those functions, one of them again is just with respect to the BP. Another one again is with respect to reabsorption of water. And I mentioned the reabsorption of urea. Let's focus on the second one. So if we have high level of ADH in this patient, there will be a lot of reabsorption of water. So if we have a lot of reabsorption of water from the nephron, the urine will be highly concentrated, and the volume of urine is going to be very small. Where do you think the water is going to? The water is going into the blood. When it gets into the blood, it's going to dilute it. Diluting it is going to make the patient to actually become hyponatremic. So there will be reduction in the sodium level inside the blood. Now relax. If you look at it, you are reabsorbing a lot of water. The total body water is going to rise. The total body water is going to rise. You remember the body will respond. This total body water that is rising go to the heart, distend the heart, ventricle is distended, atria distended. The atria that is the atria that are distended, ventricles that are distended, they will release a molecule. This molecule, AMP, BMP. The mechanism has not changed. Stretching of their wall will release this, cause these molecules to be released. They will ask you around this molecule. That's why I put an arrow on this. So those molecules will be released. So what do you think the molecule will do? So number one, this atrial natriuretic peptide and the BMP, they can cause some vasodilation and try to throw out some sodium. In the course of throwing out some sodium, fluid is going to follow them. Water is going to follow them. Then there will also be reduction in the aldosterone. All these things will cause increase in the urinary sodium. So that table question they are going to give you, they will just say, what do you think will happen to the urinary sodium? If you can remember how AMP and BMP are released and how they are going to act, you will not find that question difficult. So urine sodium level is going to be high. As the urine sodium level is high, don't forget that water will follow it. So the net result is that some of those fluid, they are going to be lost. Their body fluid that is accumulating will now be lost through the urine because of this guy. Guys, what is the net result? The net result is that the fluid has been removed, but together with sodium. So the patient will now become euvolemic, hyponatremic. So the patient will have what we call euvolemic hyponatremia. That's it. So what is the treatment that the question is going to test? The exam is going to test, that they are most likely going to test. The treatment is just fluid restriction for step 1. The most tested concept about the treatment for step 1 is this fluid restriction. That's what they are most likely going to test. SIADH, fluid restriction. That's the first line. All these salt tablet, if you like, that is what you should go and be remembering. Even if they put it amidst the option, you must never pick it. hypertonic saline is not likely the question will get there. This is more of a concept for step 2, but I will still show you in case the question get there. Diuretic, you are not likely going to, no one will set question on it for the treatment. ADH antagonist, they won't set it. I say that they won't set it. They don't get to all this level. They just test most of the time. I know, as I'm saying, some people be like, are you USMLE? Or if I do, take it easy. It makes your journey quite easy. So fluid restriction, you are revising this area. You need to revise this fluid restriction. That is the treatment they want you to bring it to the exam. Now, under which condition do you want to go for hypertonic saline as the treatment? This patient has hyponatremia. Now, if the sodium level in that question is less than 120 milliequivalent per liter, then your treatment becomes hypertonic saline. Or even if it's not less than 120, but the patient is significantly symptomatic, you may actually go for hypertonic saline. So, but watch out for this less than 120 milliequivalent. But the first line that they are most likely going to test is fluid restriction. What are the causes? They can paint the scenario. How will you even know that this question is about SIADH? Look for 3 things. No, 4 things basically in the exam, but it might just be 3. The 4th one might be, you might just need to extrapolate the 4th one. What is the first one? This patient has hyponatremia. The patient is going to present with confusion. So let us give it a beautiful name, confusion question. This patient presents with blah, 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 blah. And the patient presents with confusion. Whether you agree or you disagree, let it come to your mind that, this is not SIADH. So you just quickly check. How this is not SIADH? Confusion question. That guy was shouting. Confusion question. It doesn't mean you don't have confusion in some other condition. You have. But for this is USMLE, you want to be able to think fast inside the exam. Just see confusion. Just be like, hope this not. Just check the sodium level. The sodium is low. The next thing is go and check the urine volume. They say the urine volume is also low and it's highly concentrated. Just go through the option and pick SIADH. That's the answer. You just saw confusion at the beginning of the question. You've not even read what is there. Just go. Unless that question is asking for the cause. If the question is asking for the cause, you can't just answer it blindly. You need to check through the question and see what was the patient exposed to. So these are the causes. They just call them HELD. So head trauma. With head trauma, patients that had head trauma or CNS infection, they can secrete SIADH inappropriately. That is the reason why when you are treating that patient with meningitis, you need to reduce the fluid you give them. You need to reduce the fluid you give them. I think they normally reduce it to 2/3 of the normal or something like that. You understand all those things better. You just need to reduce the fluid because in the first place, this patient is likely going to be retaining fluid from inappropriate antidiuretic hormone secretion. Meningitis. Really? That's why if you are still continue with normal maintenance fluid, for someone that you are treating for meningitis, that patient is likely going to come down with cerebral edema. You are now wondering, where is it? I was just giving maintenance. You need to reduce it. Any CNS disorder, you need to be very, very careful. Either meningitis or anything, you need to be very careful giving too much fluid because they are most likely going to be retaining fluid. So head trauma, CNS disorder, then ectopic ADH can be released from small cell lung cancer, exogenous hormone, vasopressin, desmopressin, also lung disease, drugs like SSRI, carbamazepine. I think they love to test most of the time drugs more than any other thing. SSRI, carbamazepine, cyclophosphamide. So they might just say that the patient is being treated for depression and it's on antidepressant, and the patient now starts becoming confused. They do the electrolyte and they are saying sodium is low. The patient, once you see that, just be like, this is SIDH from SSRI. So please just note this and know peace. What about the primary polydipsia? Primary polydipsia. But before that, let me just show you one question, just briefly, just for you to have an idea. A 75-year-old man with a seizure disorder is brought to the emergency department by a friend because of progressive confusion. I've not really understood what is going on. Immediately I see confusion, I will be like, I hope it's not hyponatremic question. You now quickly trace it. Over the past 2 weeks, he is unable to provide any history. His vital signs are within normal limit. He appears lethargic and is only oriented to person. Oral mucosa is moist. There is no jugular venous distension. A basic metabolic panel shows a serum sodium of 115. There is hyponatremia. I can relate it to that confusion. But it's otherwise normal. Serum osmolality is low because of a lot of fluid going into the blood. And antidiuretic hormone level is elevated, SIADH. X-ray of the chest shows no abnormality. You are looking for all those lung pathology. Which of the following is the most likely cause of this patient hyponatremia? So you already know that this is SIADH because they say this is a patient with seizure disorder. One of the drugs that probably the patient is using is carbamazepine. So likely that carbamazepine is now the one causing the SIADH. That's the only thing you can think about. So there will always be a clincher in that question, in those questions that they are going to give. So this is one of the ways by which the question can come. All right. The last but not the least, I think there is a point I didn't mention it about aldosterone in a patient with SIADH. Body is looking for a way to try reduce those absorption of fluid. I already have a lot of fluid accumulating in the body. Body need to reduce aldosterone. Never forget this. Aldosterone level will drop. AMP, because aldosterone will be reabsorbing more sodium and the water will also follow it. So we need to drop the level of the bastard while we maintain high level of AMP and BMP. All right, so that's how the question can come there. Now, relax. Let me show you the secret behind primary polydipsia and diabetic insipidus question. So let us call this set of questions with increased urine volume. So you are reading this question and you only see the patient has been having polyuria. Let's call it polyuria question. All right. Immediately you see polyuria, the next thing is this patient has diabetes. This patient has diabetes. These people will give you the glucose level most of the time. If they don't give you, there will be another clincher that will rule out diabetes. Just quickly rush through the question and go and check what is the glucose level. You will discover that the glucose level most of the time is normal. Then this is not diabetes. So where is your own polyuria coming from? Number one, have you been consuming a lot of fluid? Number two, hope there is no problem with respect to the ADH. These are my two thinking. So I'm thinking towards primary polydipsia. I'm thinking towards diabetes insipidus. So if for me to separate these three, there is a sequence that you are going to follow. It's a ritual. There is a ritual you are going to follow. The first thing is to perform what you call, what do we call it? Water restriction. You just try to reduce the fluid that the patient is taking. If you perform water restriction and the urine of this patient, that is the patient that is having polyuria and the urine specific gravity that is very low, everything starts improving just with water restriction until proven otherwise. Your diagnosis is primary polydipsia. They will put it in the question. They will just say that the patient was denied water for this so hours. If they like, let them put it in graph. If they like, let them put it in table. Once they restrict the patient from consuming fluid and the urine osmolality starts improving with water restriction alone until proven otherwise, the diagnosis is primary polydipsia. You don't need any other thing in that question. Polyuria question that you are like, is it primary polydipsia or this there? You are just contemplating. Just quickly trace the question. Did you perform anything like your eyes just eat where they put in the question that water restriction. With water restriction, there is improvement in the urine osmolality. Don't read the question again. Just go and pick primary polydipsia. Don't finish that question. But if the question says, even with water restriction, there is nothing, then you are not dealing with primary polydipsia. you are most likely dealing with diabetes insipidus, and that will take you to the next thing you will be looking for in the question. And what is that thing? Desmopressin administration test. When you give this patient desmopressin, how does the patient react? Does the urine osmolality start changing? Desmopressin is just a form of ADH. This patient, I give this patient ADH and I'm not seeing improvement, then this has nothing to do with ADH level. Likely I'm dealing with the nephron not responding to ADH. The diagnosis will become nephrogenic DI. The question says they give the patient desmopressin and there is improvement. The diagnosis will be central DI. Show that there is no desmopressin in the first place. That is why they need to give the patient desmopressin and there is improvement. That is all you need to note. All other stuff, they are just paparazzi. The arrow, this one. No. You don't need majority of all these stuff. Just look at it. When with free restriction, what are you getting? This one, that one. So what are the causes of nephrogenic DI that you don't want to forget? The most tested concept here is the lithium. Likely you will just say the patient is being is being treated for bipolar disorder. So if you see, or mood disorder, if you see something like that, you will be thinking more towards, okay, maybe it's the drug they are using. Hypercalcemia, the demeclocycline is also there, and like if you check through the question, you don't see any drug, nothing. There is no positive history of any drug. Then you go for hereditary. That is a mutation that is affecting the ADH receptor response to ADH. So you just go for hereditary. Shikina. So there is nothing. It's something you can think out. Just check the question. Because if I tell you that this patient has nephrogenic DI, the next thing you'll be asking me is that, is this patient on any drug? And I say no. So I already told you there is no history of drug, and you are thinking drug is the cause. Where is your own answer coming from? So you start suspecting, Festus, maybe we are dealing with a particular mutation to the ADH receptor. And I'll be like, yes, I agree with you. Okay. So that is how this place is pictured. So in case they ask, how do you want to treat a patient with nephrogenic DI? In case they ask. So please never forget this HAIL. HAIL. Maybe if you can remember it. If you can't remember it, shall remember hydrochlorothiazide. So hydrochlorothiazide, low solute diet. Hydrochlorothiazide and miloride indomethacin, low solute diet. Probably this may help. And there is something about first aid. When first aid arrange treatment like this for you, look at the first. Most of the time. I'm not saying all the time. Look at the first one that is written. So if at all in the exam you see low solute diet and hydrochlorothiazide together in this patient, and I say, what do you want to give? If you can remember low solute diet, please go for that before you even go for hydrochlorothiazide. I may be wrong, but that is just what I've discovered so far. So, and that is how you'll be separating that. I wrote something here. Significance of water deprivation test is what they need you to bring into the exam, just to differentiate ADH disorder and primary polydipsia. So after that, you now start doing the desmopressin administration test. All right. Do we all get that? Do we get that? I know you are sleeping. You are just there. That let us tag along. Let's tag along. I know that's what majority of you. Let's tag along. Okay, let's look at hypopituitarism. So you need to differentiate hypopituitarism in the exam from panhypopituitarism. Now, what do we mean by hypopituitarism? The hormone from anterior pituitary, they are reduced. That's hypopituitarism. What of panhypopituitarism? When the hormone from both anterior and posterior are reduced, you call that panhypopituitarism. That's the concept number one. They just need you to know the hormones are reduced. Now relax. Let me show you something. These hormones are reduced. What is causing the reduction? I don't know. Probably you don't know. But there will definitely be a clincher in the question to guide you towards what causes it. So when you are looking at that question, you need to look out for this guy. Number one, the Sheehan syndrome. They will give you these hormones are reduced. How will I even know that the hormones are reduced? The TSH, FSH, LH, ACTH, all those stuffs, they will be low. They will be low. It might just be any two that they will just mention. At least you are seeing two hormones from the pituitary gland, they are low. Start thinking, hope I'm not dealing with hypopituitarism. The next thing is that what causes it? Now quickly run through that question. You are looking for the clinchers. What are those clinchers? At any point in time, did this woman or lady deliver, that the woman lost a lot of blood? If you can see that the patient recently had an abortion, or had an abortion about this also months ago, and it was how do we normally put it? It was what do we call it? Eventful, significantly eventful. I don't know, or adversely eventful. I think that's how we used to put it. Adversely eventful. Once you see that, you be like, probably the woman lost a lot, or they say the woman had an abortion and there is also a positive history of maybe transfusion with 3 pints or 4 pints of blood. You show that the woman lost a lot of blood or during delivery. Once you are seeing that, you'll be thinking more. And ask, what do you think is the cause of the presentation of the patient? Your answer is Sheehan syndrome. Sheehan syndrome. So the patient had what we call ischemic infarct of the pituitary gland following excessive blood loss, and that's that. So please never forget it for the Sheehan. What I know everybody knows that. So empty cellar syndrome. What can make the cellar toxica? Cellar toxica is that bone where the pituitary gland is sitting on. So what can make the chair? What can make that seat to be empty? You look, the seat is empty. What happened? And we ask, have you done any surgery before? The patient is like, no, I've not done any surgery before. So how come, where is the anterior, where is this pituitary gland? I can't see this pituitary gland again. You will start suspecting a pressure on the inside intracranial pressure that actually now make the pituitary gland to start shrinking and now become so small to the point that they are now looking for it in the to the point that the cellar toxica is now looking empty. So which pressure, or how do you think they are going to portray the pressure, that hypertension in the patient? Number one, it might be a concept of what we call pseudo tumor cerebri. You just check through the patient profile. You are having hypopituitarism. You check, the question is saying the patient has BMI of maybe 30, and patient has been having recurrent headache. Once you are seeing all those stuff, recurrent headache, BMI is high, you go for something like empty cellar syndrome, because probably the patient has been having symptomatic idiopathic intracranial hypertension. Or the question mentioned that the patient, there is a positive history of what do we call it, hypervitaminosis. Hey, maybe the patient has been treating herself for maybe very severe acne and the like. You just mention one, maybe vitamin A that the patient has been using, that you can link to that. So, but definitely you will see something like headache and the likes, that the patient has been having recurrent headache and the likes in the question. When you see that and the patient is now having reduction in those pituitary hormone, your diagnosis become empty cellar syndrome. If there is a pressure on anyone, that person is going to start shrinking. And that is another rule I feel is something we need to consider in this life. So we shouldn't really make anything to put us into unnecessary pressure, because we thinking that we are the same, but we are shrinking. So I don't think, some people say you survive under pressure. Even the body does not survive under pressure. Anyway, so that's just by the way. What of pituitary apoplexy? In this one, you have hemorrhage inside, or hemorrhage into the pituitary gland. How will I know that this patient had hemorrhage into the pituitary gland? What you will see in question is something that look like subarachnoid hemorrhage in the history that the patient had at one point in time. They might just mention something like sudden onset, severe headache with visual disturbance, the patient is having pituitary, so something that look like subarachnoid hemorrhage, all those thunderclap headache and all manner of stuff. And you are now seeing history that is in keeping with hypopituitarism, you go for pituitary hypoplasia. And usually, this hemorrhage usually occur in the presence of an existing pituitary adenoma. So never forget this, just watch out for this and you will be fine. These are the commonest the causes that they want to execute or test or ensure that you have mastered. The others, they are this brain injury radiation. So how do you now want to treat it? The hormones are already reduced. Please go and replace them. Just look at the question, which of the hormones are reduced. So once you can bring them out, you just go and, in fact, the treatment is just hormonal replacement. It's just as easy as that. Replace the hormone. All right, so that's that. Let's look at acromegaly. I'm just going to show you. I just want you to see the question. Okay, let me just flip the question for you so you can go and check it. So these are the questions. You can pause it when you get here and just answer. All right, so look at acromegaly here. So what do we have here? You have excessive release of growth hormone. And don't forget all those important concepts we mentioned. Who want to remind us the mechanism by which growth hormone is actually going to exert its effect directly? Through which what do we call it? Regulatory molecule or what?
IGF-1.
Non what?
Insulin growth.
Non-receptor tyrosine kinase.
No receptor tyrosine kinase. That's very correct. So if at all they now mention indirect effect, is through what?
Receptor tyrosine kinase.
Kinase. Just look at it and pick it. You are not overthinking it at all. So acromegaly here, you have excessive growth hormone in adult. So and usually from pituitary adenoma that is excessively producing the growth hormone. So what do I now need to note? Take into the exam. I need to cram a lot of stuff here, right? It's a lie. You don't need to cram anything. They are the things you know. So what will I see in question that will tell me that this is actually acromegaly? All right, excessive soft tissue growth problem. Hey, now you need to be very careful for excessive soft tissue growth problem palaver, because you can also have excessive soft tissue growth in some area, most especially with amyloidosis too. Here for the acromegaly, when you are reading the question, there are some clinchers you will see in the question that will tell you that this is acromegaly until proven otherwise. Large tongue with deep furrow is common to both acromegaly and amyloidosis, some amyloidosis. So this is not what you are using to separate them. You are likely to see some specific organs involvement like kidney in amyloidosis. Heart can be affected in amyloidosis. Heart is also affected here too. So you actually need to be very, very careful and be sure that that question is not about amyloidosis. All right. So the tongue can be large with deep furrow, frontal bossing, coarsening of the facial features with aging, deep voice, diaphoresis, excessive sweating, point number 1. The next point I want you to put at the back of your mind is hypertrophic arthropathy. So the patient will now start complaining of joint pain. This patient's face is changing. The nose is becoming bigger, tongue is becoming bigger, forehead becoming bigger. So, and the patient is also having joint pain. Immediately you start seeing something like this, just know you are dealing with acromegaly. It can also affect the heart, left ventricular hypertrophy, and that is can eventually lead to heart failure with preserved ejection fraction, and that is the most common cause of death in them. So they will just give the stuff and just be like, which of the following is the likely cause of mortality in this patient? The answer is going to be the heart problem. You just pick heart problem and you walk out of, you just drop the pen and bounce out. So how do you want to make the diagnosis in them? You remember, increased level of insulin-like growth factor 1, somatomedin C. So once the level is very high, you start suspecting. You now remember that hyperglycemia normally reduce the what do you call it, growth hormone releasing hormone, and that will make the level of growth hormone to be low. You will now give the patient, you perform a particular test, you call it oral glucose tolerant test. Oh yeah, jab this patient glucose, give the patient glucose. Oh yeah, egbemu, drink it. You check, the growth hormone is still high, it's not suppressed. What is going on? You start suspecting that this patient likely has abnormal secretion of the growth hormone. Do you get it? So you start suspecting that. All right, so please never forget this test. They will test it, and you can easily relate it to the analogy we did on the when we were looking at the physiology. It's quite easy and straightforward. Why are they doing it? What do you expect? There's no cramming here. If you can remember that city and the village. So if I thought you load glucose into this patient, you expect the growth hormone to actually reduce. How do you want to treat the patient? Surgical recession. So after that, you can go to treatment. Which surgery do they normally do? Transphenoidal adenomectomy. So, but surgery is surgery. Just for us to note that. In children, they can have gigantism. All right. Let's look at hypothyroidism and hyperthyroidism. So what do you want to take into the exam with respect to these two guys? For the hypothyroidism, there are some features that when you see them in question, you know that this patient actually has hypothyroidism. But before we go into each of them, what is that first thing? Anytime you are suspecting hypo or hyperthyroidism, or you are suspecting thyroid cancer, what is the first test you want to do? And that test is TSH level. You want to check for the TSH level. Never forget it. In hypothyroidism, TSH is going to be high. In hyperthyroidism, the TSH is going to be low. In thyroid cancer, the TSH is most likely going to be normal. So someone is complaining of a thyroid mass, you just quickly check through the TSH and you realize that TSH is what do we call it? It's normal. You now say, what do you want to do for this patient? You just want to go and do ultrasound. Neck ultrasound. That's just by the way. What are you suspecting? Just check through the option and be like, likely we are dealing with a thyroid cancer or something like that. So never forget that. You check through the question and the TSH level is very high. Likely you are dealing with hypothyroidism. You check through the question and the TSH level is quite low. Likely you are dealing with hyperthyroidism. Alright, let's now look at the way the patient is most likely going to present that they can put in question. For hypothyroidism, you already know them. You are seeing something like weight gain, cold intolerance, hyponatremia from excessive retention of water, dry and cool skin, coarse and brittle hair, then constipation. You are seeing proximal muscle weakness with increase in creatine kinase. You are seeing reduction in the reflexes in the question. You start suspecting hypothyroidism, bradycardia, and the likes. There is one more thing that you must never forget as you are going into the exam, and that thing is hypercholesterolemia. And I say that which of the following are you likely to see in this patient? When you realize that this patient is having hypothyroidism, that other thing they are most likely going to be testing is hypercholesterolemia. I hope I didn't say hypo the other time. Hypercholesterolemia. So where is the hypercholesterolemia coming from? It's coming from the reduction of this low density lipoprotein receptor. So the low density lipoprotein receptor, normally they are supposed to, liver normally push them out to the go and bring the LDL for me. So because there is a reduction in their expression, those LDL and their associated cholesterol will still exist in the system, so the level will now be high. So never forget this hypercholesterolemia in relation to hypothyroidism. What about the hyperthyroidism? What do you want to put at the back of your mind? You already know them. Weight loss. You know the sodium potassium ATPase. So increase in synthesis of it, and they've tested it before, which is going to cause increase in basal metabolic rate and increase in calorie genesis. Then you can also they also can have proximal weakness. However, yeah, their own proximal muscle weakness is not associated with any other abnormality with respect to creatine kinase. All right, if you see, they can have hyperdefecation, diarrhea, increased appetite. Please note it. For me to put arrow on this guy is because you need them and they've tested them before. Fine tremor, chest pain, and systolic hypertension and the likes. Then they have reduced LDL, HDL, and total cholesterol. So there is one more thing. Anytime you read any question on thyroid pathology, and that question shows or mention a patient with esophthalmos, until proven otherwise, you are most likely dealing with grave disease. So you just show you a diagram alone and you see that staring gaze. Just that diagram, they now give you 25 pages of history. Don't bother to read them. Just close those history and just go and pick grave disease. That's more than enough, because that is enough a clincher for you to nail the diagnosis. That's why I needed to put this in red. All right, so let's come down to hypothyroidism causes. There are some causes of hypothyroidism, and I want you to pay attention to them, the way they are going to be tested in the exam. The most common cause of hypothyroidism, we peg it on thyroiditis. Now, you remember, I told you that anytime you are reading question and you see them mention something related to thyroglobulin, it should draw you closer towards the thyroiditis. And be like, hope I'm not dealing with thyroiditis here. All right. So never forget that. So you read this question and you are seeing them mentioning maybe this thyroglobulin level is high, this, that, blah, 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 and the like. You are dealing with that. Now, what are the examples of this thyroiditis? We have Hashimoto, we have subacute, we have Riedel. These are the three forms of thyroiditis you want to put at your left hand while you are going into the exam. Now relax. Let us give it another grouping. Another grouping we are going to give thyroiditis is painless and painful thyroiditis. It shows that when you read the question in the exam and you realize that this patient is having hypothyroidism, you check through the option. You are like, you are seeing Hashimoto, subacute, Riedel, blah, 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 something like that. The next thing you want to check through in that question is it tender? Is it painful? That's all. If the question says it is painful, the answer is subacute. If the question says it is painless, you are either dealing with Hashimoto or Riedel. Now, that is more or less like a background information for you. Just like this is like hypothyroidism. You are looking for the cause. This is not related to drug or anything. You've checked through the options. You are seeing option A, Hashimoto, option B, subacute, option C, Riedel. Then now go and put some other stuffs. Then just quickly check through the question. Look out for pain. If it is painful, go and pick subacute. If it is painless, it is either Hashimoto or Riedel. Then you are now going to separate them. Now, let us look at the Hashimoto. They tilt more towards the pathology, description of the pathology most of the time. Histology, description, and the likes. So, this is also called chronic autoimmune thyroiditis. What it means is that if you are seeing a patient with hypothyroidism and you check through that question, you are seeing some other autoimmune in that patient. Until proven otherwise, you may be dealing with you are dealing with Hashimoto. This is a patient with hypothyroidism, and I checked the question. I'm also seeing something related to type 1 DM in the patient, or I'm also seeing something related to Addison disease in the patient, or probably the patient even have SLA. You will be thinking more towards Hashimoto. It is autoimmune. Never forget that. And that is number one. Number two, it is the most common cause of hypothyroidism in iodine sufficient region. Okay, let me even assume that I remove that iodine sufficient region. The most common cause of hypothyroidism is Hashimoto. So what does that one mean? You read through the question. This is hypothyroidism. There is no clincher. You check, no clincher, nothing. The patient was seen by one amateur that does not even know how to even examine or know what to check for in the patient. And you are now like, what is now the diagnosis? All what you want to use to separate them, they are not there in the question. They now list the answer. You use statistic to pick your answer. And that is the Hashimoto. It is also the most common. That's another point you want to put at the back of your mind. It is associated with HLA-DR3. Just put that at the back of your mind. Because it's autoimmune, there is a risk of primary thyroid lymphoma. A very good example is diffuse large B-cell lymphoma. So please note this very well. What are the findings? The findings you are going to see is this thyroid gland is enlarged. Why is it enlarged? There is hypothyroidism and the TSH is high. TSH continues to stimulate the thyroid gland to produce this hormone, produce this hormone, produce this hormone, produce this hormone. And that will make the thyroid gland to start increasing in size, but it's not producing the hormone. So hyperplasia. So there can be increase in size, moderately enlarged, non-tender thyroid. Then this may be preceded by transient hyperthyroid. I will tell you how that one will present and how you will break it down in the question. Now, what are the antibodies they are going to ask in the exam? They will test, they can mention this antibody in the question. That is anti-microsoma. Or another name for that is antithyroid peroxidase. Then antithyroglobulin antibody. I'm not surprised that we are mentioning antithyroglobulin because in thyroiditis, there is supposed to be thyroglobulin spilling out. So if you are mentioning antibody against that thyroglobulin, then I'm not surprised. The second one is antithyroid peroxidase. Now, they know that you know thyroid peroxidase, but they may not mention thyroid peroxidase in the exam. It might be anti-microsoma that they are going to mention. So you want to note the name and the second name of this thyroid peroxidase very well. And the fact that antibody against it and the fact that it's also called anti-microsoma. What about the histology again? What will you see? You call it O2 cell. When you read question and you see them mention something about O2 cell, these are actually, when you see O2 cell being mentioned, let me show you the O2 cell in the diagram they put here. So these are the O2 cell. You see them like this. You know, you will have read the question and you see. If you like, let me assume that you are not actually, where is this one coming from? So you are not actually sure of what is going on. So you will be more, sorry, 1 minute. You are not sure of what is going on in this story. Just go back to the story. You will understand where the slide is actually coming from. All right, I don't know where this is coming from. Sorry. Okay, let's continue. All right. So that is about the Hashimoto for us. There is a particular variant of Hashimoto. You call it postpartum thyroiditis. Just someone that recently delivered within a year, and the person is now coming down with symptoms and signs of hypothyroidism. You'll be thinking towards postpartum thyroiditis. So I put all these things together in non-Hodgkin lymphoma, NHL. Well, it's not a big deal. Even this diffuse large B-cell lymphoma is a form of non-Hodgkin lymphoma. When we are doing hematology, we will unravel the mystery behind them. So N here is the fact that it is non-tender. H is the fact that you will see O2 cell. L is the fact that you can see lymphoma aggregate. So please never forget all the important points we've made. This is the most common. Never forget that. What about, I will still mention that transient hyperthyroidism and how you go about it. What about the subacute granulomatous thyroiditis? What will you see in question that will give it out? the fact that it is what? It is painful. Once you see pain, tenderness there, just know that you are dealing with subacute granulomatous thyroiditis. Subacute granulomatous thyroiditis. Tenderness there is the key word. The other things they will put in question that will give it out is the fact that there is most of the time preceded history of viral infection. They will say that the patient had a recent viral infection now coming down with neck mass. Now it's painful. You are like, hope this is not subacute. All right. Other thing they might say, with further evaluation, which of the following are you likely to see in the patient? The answer is elevated ESR. They've tested his ESR before in the exam. Viral infection, they've mentioned it in the question before. That will help you to diagnose subacute, and tenderness is another thing they will put in the question for you. What about radial thyroiditis? 1 minute. All right. So that is for the subacute. So don't forget the pain, don't forget the viral infection, don't forget the elevated ESR. They may ask you for what kind of inflammation are you going to see. The name has spoken for itself, and that is the fact that it is granulomatous. So just pick granulomatous inflammation, and that's that. What about this radial thyroiditis? Radial thyroiditis. I call radial rebel a rebel. I hope that's the pronunciation. I don't know. I think in Yoruba, is that not more or less like a bastard omoale or something like that, or something? I don't know. You can look at it. Just get the gist I want to give you there. So it's a rebel, something like it can jump, live wherever it's supposed to be, and invade into the surrounding structure. So they now give it a very beautiful name, and that is invasive fibrous thyroiditis. Now relax. Imagine where the thyroid gland is. Imagine the structures that surround that area. You already know that the TSH in this patient is high. You now read the question, they talk about the neck mass. The next thing you start seeing is something related to dysphagia. You are having dysphagia. You have something related to some structures around the neck that are having compressive symptoms. When you are seeing that, you'll be thinking more towards radial. It's not tender. You can have fibrosis, and you can also have some inflammatory infiltrate. Never forget, it's not tender. That surrounding structures compression is what will give it out very well in the exam. I put an arrow on something here. The fact that it may occur as part of IgG4 related disease. Which condition? What are the examples of conditions that are related to this IgG4? Autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. I just want you to note it. I think I said, I'm not sure. That's why the arrow on it is quite thin. So I think I've seen something related to that before, but just for you to note it, IgG4 related disease spectrum. So, and that is what we have there. Now, come down to congenital hypothyroidism. Congenital hypothyroidism. The most tested concept under congenital hypothyroidism is, what do you think is the cause? How will you know that this patient is having congenital hypothyroidism? You see this 6P. You don't need to cram any P. Just remember the fact that the patient is going to have a protruding umbilicus and protuberant tongue. If you look at I think there should be a diagram. So you see something like this. You see something like this. Let me assume that this is actually a baby. So you see something like this. See something like this diagram. Can you see the tongue of this baby? And they can also show the umbilicus. When you see the umbilicus that is protruding and the tongue is like this, there are two differentials you have. The first one is, are you dealing with congenital hypothyroidism or you are dealing with Down syndrome? Most of the time, it's only going to be one of them they will list. If at all you see two of them given in the option, then you need to check that question very well. They will have separated them. So you must never and never forget this. This is highly high yield for you to note. All right. Sorry, please don't be annoyed. Okay. So that is that. Protruding umbilicus. Then never forget the what do we call it? Protruding tongue, protuberant tongue, and the protruding umbilicus. All right. The other causes of hypothyroidism, it can come from drug, it can come from any other thing. Now, let me quickly talk about this thyroiditis, the spectrum that they normally follow. So think about it. This is actually the follicular cell. So they have the thyroid hormone in them, and they also have the thyroglobulin. So when they lyse, they are broken down, the thyroid hormone will be released, thyroglobulin also will be released. So you can easily deal with the thyroglobulin. You will see it being elevated in the question. What about the thyroid hormone? So that initial increase in the thyroid hormone will give the patient symptoms and signs of hyperthyroidism. That is the reason why anytime you see a patient with hyperthyroidism, you also want to be sure that you are not dealing with thyroiditis. You want to be sure that this is not a patient with thyroiditis. So you will see the way we are going to look at it. All right, after a while, this hyperthyroidism will drop to euthyroid. Then later, the other part of the thyroid will respond by producing more. We continue to drop again, come down to hypothyroidism. Then after a while, with this hypothyroidism, the thyroid gland is going to respond to that and want to raise the thyroid hormone level up again and bring it back to the euthyroid state. So this is what you have. Now, how are you going to treat? Number one, it depends on the state that the patient is coming. If you are dealing with hyperthyroidic states, and you've already understood that this is a thyroiditis question, they now say, what do you want to give to the patient? And you are now shouting antithyroid, you will be completely wrong. The cells are lysing. The remaining cells that are supposed to ensure that the patient is okay, you want to go and give drug to inhibit them. That will be wrong. So the only treatment in hyperthyroidic state you must never forget is beta blocker. The only treatment you want to give, once you realize that this is actually thyroiditis, even if the patient is now presenting in hyperthyroidic state, that's what you want to just give beta blocker. Because those cells are dying. The remaining cells need to survive. You just want to limit all those excessive sympathetic, all those excessive receptor activation, B1 and the like. You just want to ensure that the patient is okay. If you are dealing with a painful thyroiditis, the patient is having pain, then you can give the patient NSAID or you give the patient oral prednisone. All right, so that is what we have with respect to this area. So never forget that, and it shall be well with you. What about the hyperthyroidism? We've looked at the hypo. Let us look at the hyper too. What is going on with respect to hyper? With respect to hyper, these are the examples. So I will first of all list, I will say thyroiditis, number 1. Number 2, grave disease. Number 3, toxic multinodular goiter. Number 4, we can also have toxic adenoma. Then we have thyroid storm. Now relax. Let me try to show you what you must never forget. So this question, how I will know that this is hyperthyroidism? You look at the TSH. The TSH in this patient is going to be very low. So you will check the range that will be given. You just realize that it's lower than what is expected to be. So now I already established that this is hyperthyroidism. Check through the question. If they mention anything about eye symptom, if the question mention anything like esophthalmos, if the question shows any diagram like this, don't bargain it. You don't even need to read that question finish. Go for grave disease. You just go for grave disease. I'm dealing with grave disease, and raise up your hand the way our president used to raise it up. That's it. Just pick grave disease and go. So now, what are the other questions they may be asking with respect to grave disease? Question number 1. What is that thing that is stimulating the thyroid, those follicular cells to produce all those thyroid hormone? The answer you are going to go for is thyroid stimulating immunoglobulin, TSI. They are the ones stimulating the TSH receptor on the thyroid that is making the patient to have what? Hyperthyroidism. Also making the patient to have diffuse goiter. First of all, why are you shouting like something is wrong with you? I will tell you why I shouted diffuse. I will show you. Another thing that those immunoglobulin can do, they can also stimulate what we call the derma fibroblasts. Can you see that those immunoglobulin are doing wonders? They stimulate the derma fibroblasts. That's why the patient can develop what you call pretibial myxedema. So pretibia, just at the front of their tibia, you will just see some evidence of something like edema there. Then they can also go and stimulate orbital fibroblasts. Fibroblasts you find in the orbit. So when they are stimulating those orbital fibroblasts, those ones, they will start releasing what you call GAG. So when they are releasing this GAG, that GAG, they are actually osmotically active. They will be drawing water to themselves, and the next thing that you start seeing in the patient is that the eyeball will start coming out. USMLE will ask you these wonders that this TSI are doing. TSH receptor stimulation, fibroblast stimulation. Where do you find those fibroblasts? In the derma, in the orbit. They are going to be stimulating them. So please never and never and never forget all these stuff. So please never forget this at all. They stimulate these guys. They stimulate the derma fibroblast. They can also stimulate the orbital fibroblast. Another important thing you need to note there is activation of T cell and lymphocytic infiltration of the retroorbital space. Increase in cytokine 2 is also contributing to the esophthalmos, apart from the one we mentioned. All right, so please never forget this. Esophthalmos will give out the grave disease. What else? What else do you want to take into the exam? The next thing is this HLA-DR3, HLA-B8. First of all, we've seen HLA-DR3 before in a condition. You say, yes, you've seen it before. And it's actually in Hashimoto. So now, what are those HLA-DR3 associated conditions? I give them this beautiful mnemonic. STAG, S-T-A-G, Hashimoto, STAG ASH, or ASH STAG, ASH STAG, ASH STAG, or ASH TAG. You remember hashtag, the way I think when you are typing or something. All right. ASH can be Hashimoto, S at the front of that hash can be SLE, TAG can be type 1DM, A is Addison disease, G is grave disease. That can actually be it. All right, so that is for this grave disease that you want to note. Please let us know. They can also describe the histology for you. They are usually described tall, crowded follicular epithelial cell with scalloped colloid. This description is very high yield for you to note. That is for grave disease. So these are just the points they are going to be asking. They can ask about this cytokine. They can ask about what is stimulating the thyroid follicular cell. They can ask about the diagnosis. These are the basic things they ask. All right, how do you want to treat? How do you want to treat the patient? So we're going to let's look at toxic multinodular goiter. Toxic multinodular goiter. That is very easy. The description they will give in the exam is what we give it out. So this is what you have. This is the thyroid gland. Permit me to just represent it like this. This is another thyroid gland. So permit me to just represent it like this. So these are the thyroid gland. The difference between the toxic adenoma and toxic multinodular goiter, that word toxic is coming from the fact that those thyroid glands, they are producing something. Like they are start producing this thyroid hormone. So you call it multinodular because you see multiple nodules. So when they describe them, this is what you are going to see. You will see a particular hot nodule. You call them hot nodules. They are hot because they are actively producing something. Permit me to just show them like this. Whereas toxic adenoma, you will see something, just one particular nodule, just one, and that nodule will be producing thyroid hormone. Now, so when now this is the one for grave disease. This is also producing thyroid hormone. This is the one for toxic multinodular, also producing thyroid hormone. This is another one for the toxic, is also producing thyroid hormone. How are we going to separate all of them? What are you going to use to separate them all? And that is actually when you are going to come into this radioactive iodine uptake. That is when you come into, when you read the question and you are seeing all those radioactive, you already understand what they were trying to do. I'm only seeing this thing. Probably they are not even putting esophthalmos in the question. You don't know what is going on. Or probably the patient is not even having esophthalmos yet. You don't know what is going on. You are just seeing this thyroid hormone are just high. You check for thyroid globulin, is not there. You are thinking towards these three guys. What is going on? They will now put in the question that radioactive iodine uptake is actually done. And when they do it, they see that there is diffuse uptake. If the question says there is diffuse uptake, the answer is grave. If the question says there are multiple areas of increased uptake, the answer is toxic multinodular. If the question says there is only one area of increased uptake, the answer is toxic adenoma. Something like that. So that is how, or what do we call it? How the question can actually come in a way. So once you read the question, you have an idea of what is going on. All right. So that is how you are going to be dealing with this guy. Toxic multinodular, toxic adenoma, blah blah blah, and the likes. So how does toxic multinodular goiter come about? They have TSH receptor. So we just see them, the TSH receptor in those areas, they just start becoming activated unnecessarily. Like TSH is bound to them, and they start stimulating that particular area to be producing thyroid hormone. Immediately we see that we have TSH. Why are you stimulating them? TSH say, I don't know anything about it. We now check. We realize that there is a mutation. So there is a mutation in them. That mutation in those TSH receptor is what is responsible most of the time when you see focal patches of hyperfunctioning follicular cell. And that is that. What about the thyroid storm? Thyroid storm. What about it? For the thyroid storm, you just realize when they call something storm, it is actually storm. Indeed. So you just see this, you see this state of hyperthyroidism. Sorry. You just see this state of hyperthyroidism usually when this patient is actually hyperthyroidic right from the beginning. So there is now a more or less an acute stressful situation. A very good example is maybe there is infection, they want to do surgery for the patient and the likes. You now start seeing something that is related to neurocognitive function in the question. Once you are seeing neurocognitive decline in the patient, like the patient is becoming delirious, is becoming agitated, in a patient that is hyperthyroidic, until proven otherwise, you are dealing with thyroid storm. So they are doing surgery for this patient that is having hyperthyroidism, and the next thing the question says is that the patient has been shouting on the ward. The patient is now having some delirium. They now say, what is the diagnosis? Thyroid storm. All right, let us look at the treatment. Before we go to the treatment of thyroid storm, let me show you how you are going to treat hyperthyroidism. You see this order. This is the order you are going to be looking for in the exam. You call it BAT, not the BAT you know in Nigeria. This is another BAT entirely. So BART. It is the order they want you to bring to the exam. What is the order? This B is beta blocker. So anytime they give question like, oh, what is this? This one, just be looking for beta. That's the first drug. If the question says beta blocker has been given, is there any other drug you want to give to this patient? Anti-thyroid. But never forget, if that hyperthyroidism is from thyroiditis, you don't give anti-thyroid. Never go there. Never pick it. All right. Most of the time, the treatment will just stop here until proven otherwise. So after that, you can go to radioactive ablation. Then you can also go to thyroidectomy. All right. So that is what we have there for the treatment. What about the thyroid storm? Let's look at the order. The first thing you want to give to the patient is beta blocker. The next thing you want to give to the patient, the next thing you want to give to the patient is actually anti-thyroid. Now, there is a caveat to the anti-thyroid you give to a patient with thyroid storm. This patient is acutely having a particular condition. If that is the case, I need to give that anti-thyroid that will help me reduce the conversion of T4 to T3, at the same time also reduce the production of the thyroid hormone. And the only anti-thyroid drug that suits into those attributes is the propylthiouracil. So now, they will tell you that the patient has thyroid storm. They've given maybe beta blocker. They now say, which of the following do you probably maybe that the patient will also benefit from? You now see any of the anti-thyroid, now want to pick. No. It must be PTU, not metimazole. You don't go for metimazole here because metimazole does not have that added advantage. All right, so that is about the anti-thyroid. So the next thing you want to give to the patient is something like this iodine. You call it potassium iodide, and the last thing you can give to them is glucocorticoid. So please watch out for this BIG. I call it BIG. This is BAT. This is BIG. You can go into the exam forgetting what do you call it? Forgetting the order. That would be like you want to swim in shark infested water. All right. So that is why I say you should note the treatment. Please never forget the treatment here. I'm going to stop on the hyperthyroidism, Jod-Basedow phenomenon. Jod-Basedow phenomenon, the thing about it, I can only illustrate it for you so you will understand. I used to give this illustration in Africa, in Nigeria, for example, that I'm used to. So they taught us some stuff that we only imagined them. We didn't really see them. They taught us everything about the heart. I don't think anyone sit down and look into the heart, into all the chamber and see that this is atrium, this is mitral valve, and see all those stuff. But we can imagine it. So you now imagine with that kind of behavior, we have upregulated our imaginative skills to the point that you just need to say one thing. Our brain will start linking and be like, this is likely going to be the way it looks and the likes. You now find yourself in United States of America where they are showing you everything. How do you think you are going to absorb the knowledge? The way you will absorb them and make use of them is going to be beyond this world. And that is what is happening in Joad-based phenomenon. This patient has been living in iodine depleted area most of their life. The patient has been having, so the thyroid gland has already upregulated most of its mechanism of producing this thyroid hormone. When you now introduce iodine small to them, the rate at which they produce thyroid hormone is very high. When you see that, that phenomenon is Joad-based phenomenon. It is opposite of Wolff-Chaikoff, because in this one, thyroid hormone is produced, thyroid gland is producing thyroid hormone. In Wolff-Chaikoff, thyroid gland is switching off the production of thyroid hormone. So you can see this in a patient that has been living in iodine depleted area and has been struggling and surviving. You now go and perform one contrast test for the patient. You give the patient the intravenous contrast that contain iodine, and the next thing is the patient start having hyperthyroidism. All right, that is Joad-based phenomenon. So what are the causes of goiter? It can be toxic multinodular, thyroid adenoma, thyroid cancer, thyroid cyst. It can also be, that's when it's nodular, when it's smooth, grave disease, Hashimoto thyroiditis, and the likes. All right, so I am going to stop here today. By God's grace, we are going to finish up the endo tomorrow and start GGI. Thank you.